get started. So you can just put it.
It's so quiet. Thank you. It's been a long journey. It's been a couple of months since you started on the journey. It's been more than a year since we as the organizing committee started on the journey. As briefly explained yesterday, I don't think we really realized 1 year ago when we kind of started to have our first online meetings, to kind of even go through the idea of having something like this, that we would have so many people actually attending. There would be so much interest from so many countries, from so many professions to actually take part in Innovate4AMR. Also to kind of give the judges a bit of an idea on how the whole project came to be. So 1 year ago, we started our email conversation with Anthony and Virginie in React about an idea to create something related to innovation on AMR. Before we actually moved into the projects, we had lots of long discussions on AMR and how we see that the youth could definitely play a bigger role in tackling this problem, not just because we're the youth, we're the future healthcare providers, but this will have such a huge effect on all of our professional lives. So from there on, we kind of started planning the whole journey that has taken us to this point, and it's been quite exciting. And we're really thankful for all the sponsors that join us for this project, especially obviously React, then WHO, and then South Center. Without the support of such big organization and your professionality, organizing this workshop would not have been possible. We definitely do look forward to having a continuation of this collaboration, as there's obviously a great interest to engage the youth and work more with innovative solutions when it comes to AMR. In the end, it is a common project. But now for the teams, it's an exciting moment. You've been training your presentation now for quite a while. But as we said also on the first day, just being here means that you're winners. You went through a really extensive, I wouldn't call it a vetting process, but you made it to the selection from 145 teams. And that is a big victory. The idea of having you do your presentation here is just a way for you to receive feedback on your project from the expert panel that we've gathered here, and to give you more knowledge and be better equipped to start implementing your projects once you go back to your home countries. So the whole idea of these presentations is to just provide you with a platform to get feedback and train the skills which are necessary for the implementation of the projects once you go back to your home countries. I think without further ado, we will not start the presentations here. We will introduce the wonderful judging panel that has agreed to come here to judge your project. I think we'll start with, is it actually Nikolai is the most left one? So do you want to give a short introduction to yourself?
So I'm the most left winger, you said?
Yes, yes. Not politically.
I'm just repeat. It's fine, it's going to be fine. So yeah, my name is Nikolai Magrini. I'm the secretary of the Essential Medicine List. I was here yesterday, and as a background, I'm a medical doctor, I'm a clinical pharmacologist, and mostly work in guideline development and methodology. But then, getting older, I tried to work more on implementation, and what I learned is development is difficult, and implementation is much, much bigger. And maybe Anand can tell you something on polio eradication. So we don't know exactly the proportion of the difference. And AMR, as you've been shown right now, is huge, but now I think is well framed.
Thank you.
Hi, I'm Elizabeth Long. I'm a behavioral designer, and I'm really excited and honored to be here with Innovate4AMR and WHO. I've gotten the opportunity to teach the team some
Elizabeth.
Good morning. My name is Anand Balachandran. I've quite recently joined AMR, but I have extensive experience in the world of polio eradication, primarily in the areas of behavior change, engaging, empowering communities, and a lot of political advocacy because we have to access communities that are the most disadvantaged and reach them with a vaccine and overcome their concerns and so on and so forth. My background is in sociology, anthropology, and law and diplomacy. I'm not a medical professional, but I tend to view public health projects from a very different perspective, from a non-medical perspective, and sometimes that's the way in to solve the problem. Thank you.
Thank you, Anand. Wow.
Yes, it's such a pleasure to sit here with all the winners. My background is I'm a medical doctor, epidemiologist, and medical microbiologist, but I'm passionate about public health and how we can change the world into a better place from a health perspective.
Okay.
So, good morning, my name is Francis Moussi. I'm actually a biomedical engineer by training, so which there are not so many at WHO. I worked in academia for many years, for 20 years before joining WHO, so I went through the various ranks up to full professor. In WHO, I am now doing work on diagnostics for AMR and also for other things. For example, we recently launched a list of essential in vitro diagnostics. So it's a real pleasure for me to be with students today, so I really enjoy it.
Good morning, my name is Arnaud. I'm a scientist as background, neither a physician or pharmacist, but I work on surveillance of the use of antibiotics now for almost 20 years, and I joined 2 years ago WHO to expand my activities with other part of Europe. I worked with Europe before, and now I'm in charge of trying to establish surveillance system for use of antibiotics in the other regions and targeting mainly low-income countries. And just, I don't know if I've been told, but we just released the first WHO report on antibiotic consumption on Monday, including some data from the low-income countries.
So good morning, I'm Theodora Lee. I'm a medical officer at WHO, and I'm in charge of sexually transmitted infections, and I'm in charge with AMR in gonorrhea, and also developing guidelines. You know that sex is everywhere, and it's always like this is the topic that they don't want to talk about. So I have the loudest voice because they don't want to acknowledge that gonorrhea is one of the biggest problems when it comes to AMR. And although it doesn't kill, later on, if we don't take care of it, we will have, or even the politicians and all that will have dripping penises. So that's what I told the people from the US. And so please, as you move forward, please think of it. Sex is everywhere, and you might have at some point gonorrhea, and that you need to pay attention to it as well. Thank you.
Thank you, Theodora, for opening the floor. I think it will be fine. Thank you so much for arriving here to be as judges. So now to going to say what we are expecting. So we have 11 teams, out of which 10 are here in place. We will have one online presentation. Each team will have 10 minutes of time for the presentation, followed by 5 minutes of questions and answers. I will be strict on time. I will cut you off. You know I can be nasty. But just in sake that there's so many presentations that we had to take care of the time management also. I think without further ado, we can start with the first team. The team that has the honor to start the competition comes from Peru. We've had long discussions on how to pronounce their team name. We're not sure if it's AMR Sharks or AMR Harke, but I think Alicia and Omar can also tell how it's rightly pronounced. So please welcome. Alicia, you can be here or you can be there as you wish, guys. We won't have a microphone there, but we will only have the microphone here. Is it fine? And for changing the slides, Virginie, will you be? Do you want me to tell like 1 minute? Sure, so when this microphone, okay. You can check if it works. All right, can we give one more applause for Alicia?
Okay, good morning, honorable public. We are Omar Villota and Alicia Maldonado. We come from Peru and our project is called AMR Hardcare Project, which means AMR prevention on Quechua, which is a language in our country. So first, we want to talk a little bit about our beautiful country, Peru. It's very diverse and we have three languages that are spoken. Mainly it's Spanish, but also Quechua and Aymara. So we wanted to give our project a focus which is culturally sensitive to address AMR, which is a growing problem in our country. So our problem statement is focused on pediatric population, because what happens? Mothers are the basic caregivers of their children, and when doing their best attempt for the well-being of their children, they may have an improper misuse of antibiotics, and also because of the conditions in which they may live. Even in urban areas, they are sometimes far away from the primary healthcare settings, and in rural areas, this is completely worse. So our objective is that these mothers do a pertinent use of antibiotics in the search of the well-being of their children. And the context in which we will carry these interventions are in nursery and primary schools, because in this way we will assure that the parents, especially the mothers, because they are the ones that are more in care of their children's well-being, are attending. So in this setting, we will address these issues through interventions. Not with a lot of technology, because in our country, many people, even in urban areas, don't have smartphones, don't have access to television or other modern communication types. So we want to go there to these schools and actually give them all the information they need, so that they can have a better use of the antibiotics. We also want to deliver these interventions in Quechua or Aymara, because public policies are sadly not done in this language. They are only done in Spanish, and we want to give a different focus to leave no one behind these important interventions. And well, our rationale about this project is that we are focusing our interventions on mothers' education, because they are the direct caregivers of their children's health. If they acquire the knowledge, they may change their beliefs in the long term and start using correctly the antibiotics when needed. They may also be agents of change, and this will empower mothers that also live in their communities, and this will be for a long-term time. So we can have an environment, a culture, a local culture of AMR awareness when doing these interventions. And of course, we are looking for behavior change after the knowledge is given to them. So our implementation plan starts in a training phase. We come from IFMSA Peru, which is part of the International Federation of Medical Students Associations, and we have a lot of medical students that are involved in several campaigns regarding public health. So we will, as coordinators, we will contact other medical students with experience on AMR to be facilitators. Medical students which are like on in 5th or 4th year of the career, or maybe interns as well. And we will send a call for volunteers from many parts of Peru. especially from the cities from the cities and areas that we want to give interventions. And then we will do online trainings to our volunteers. Online trainings because it's very difficult to have all the students in one place. And the topics that will be covered in these trainings will be AMR and pediatrics, approaching to the population in a culturally sensitive way, because we have to know how to reach the population, how to make them understand us. And also the use of measurement instruments, because we want to do a very a good evaluation of these outcomes. Then we are also doing the stakeholder mapping, in which we will establish the contact with the Ministry of Culture, because we will need help in the part of the translation, and also maybe support with people that talk both Quechua and Spanish, or Aymara and Spanish, so that they can help us with the material and also in delivering the interventions in the settings and the schools. We will also coordinate with the nursery and primary schools, because the medical students of IFMC Peru already do campaigns at many schools, so we may contact these schools that were previously contacted for other previous campaigns. And we will also contact infectologists and WHO specialists to receive constant feedback on our project, and also support on materials that we will deliver, because we will not only deliver interventions but also give infographics for the people to have them and read them whenever they want. Okay. We will do the materials and also translate them to Quechua and Aymara. And these are the causes that we identified that arise in both urban and rural population. It's kind of different, because we saw that there are some topics that need to be covered in both populations, like differences between viral and bacterial infections, importance of complying with the whole prescription, the importance of only using antibiotics only when needed, and recognizing that using it unnecessarily can do more harm than good. But also in the rural population, we have to address accessibility barriers. And there is an example of their mothers that save antibiotics from previous infections to treat their children when there are new infections that arise, and we have to. And this is because the health services are not that accessible in rural towns, so we want to address this issue. And also, to access cultural beliefs towards antibiotics. Maybe there are beliefs on the local towns about antibiotics that we would like to know, and to know how to address them, to make like a good balance between what's evidence-based correct use of antibiotics, and also their cultural beliefs, because we have to respect them, as the culture is very diverse in Peru. So first, in our workshop, we would like to do a short survey, and then introduce these topics bi-monthly, like four times a year. We would like to do it, and then doing a recap of the previous topics, and then we'll use case studies just to make it practical, and finally do a post-test after each intervention to assure that the information was correctly given. Well, in this part, I would like to give
for monitoring and evaluation, as coordinators, by monthly, we will come back to the schools to apply the post test, and by this way we can see how or what will be our impact, and the communication channels between coordinators and participants are inclusive languages. For instruments, is pre and post test to know what is the knowledge they can know. For final surveys, apply 2 months after, and then the interviews with mothers seeking behavior change. Okay, we hope at least 10 schools reached. It involves 100 mothers, because each school have close to 300 children. 4 cities reached, because we found some papers that they say that in these cities, Lima, Piura, Arequipa, and Cusco, places where the people speak Quechua, Aymara, and Spanish, they found some antibiotic resistance, and this is the reason why we choose these cities.
1 minute.
For strange, our culture is very sensitive, and the people who think with work is very involved and empowered. We are talking about IFMSA Peru members, and next, please. Okay, the risks. We need found some people or someone who talk Spanish and Aymara and Quechua, and this is the reason why we need the Ministry of Culture. And well, the people have a lot of conflict with their beliefs, and it is maybe a risk for us. For limitations, well, frequently the parents don't have a lot of time to make or to do these campaigns or to talk about these topics, and it is a limitation for us.
Thank you. Time's up. Oh, that was perfect. Alright, so next we have time for the questions. So you raise your hand up if you want to ask questions. Omar.
Thank you very much. This is very interesting, and but you mentioned that you would like to focus on others because the target group is young children. Do you have data about the use of antimicrobials in the different age groups that could substantiate, you know, why you choose for this group?
Well, yes, there are some papers about infections on children which are less than 5 years old, also on neonatal medicine. So yes, there. Well, actually, AMR is seen in every group of age, but we also see it in this population. We wanted to focus it in this because yes, there are papers that which show that there are increasing resistant rates, and so, for example, in pneumococcal infections. But we also wanted to focus on this, on these children, because when their mothers learn about how to use properly the antibiotics in a younger age, then they will continue with this behavior and all the way of the child growth. So when they are also adolescents, when they are teenagers, or older kids.
Yeah. So if you have a mother coming with a child who has acute fever, so what kind of advice do you want to give to this mother?
Yes. We would like to them to know that if the child is ill, for example with a fever, they should seek for a doctor advice, and well, we also expect that from the doctor perspective that they are well trained to prescribe correctly the antibiotics. But well, the doctor will establish if it's a viral or bacterial infections, and the mother should understand that viral infections are not treated with antibiotics. So that's why it's one of the interventions that we propose, and in that way they understand that if the doctor does not prescribe them the antibiotics, it's okay, it's the correct way, and also that maybe the child may be ill, and there's a natural course of the illness, so they may have also a cold, they may have still rhinorrhea, but we want them to know that this is normal, that this can just pass, and with no need of antibiotics, so that they can be more they can be more confident that what the doctor is saying about no antibiotics is good, and that the child will not get bad. more ill.
Next is Theodora and then Elizabeth.
Yeah, thank you so much for this presentation. Following up on Francis' comment about the mother and what you need to be doing to the child if the baby has a fever. So in your implementation plan, you said that you're going to be engaging the Ministry of Culture, but how will you then make sure that you also engage the healthcare provider within these different cities that you're going to be doing the intervention?
Well, to the healthcare providers, in rural towns there's usually one primary healthcare facility. So, and it's also part of the authority because they see the doctor there as the only doctor there as a very respectful authority. So yes, part of our project may also coordinate with them. So because it's important that mothers understand about the difference between viral bacterial infections and the properties of antibiotics, but the doctors also need to have a good training. So maybe the scope of our project does not cover that part, but we would also like to do more, not only stick to this, but also see it from the focus of the doctor's perspective, so that they can be adequately trained and follow guidelines that maybe they do not follow because they may be, usually the doctors that go to these rural communities are young doctors just graduated, so they may need some training on how to prescribe all the antibiotics and also how to develop the physician-patient relationship, because it's important to have a good communication with the mother and explain them well, have even good handwriting, so that they can understand well why the doctor is saying this, but also with a good evidence based on clinical guidelines.
Time's up. Sorry, Elizabeth. Alright, can we give one more big applause for AMR? Alright, time for the next team, which is Armed from Philippines.
Thank you.
Can we start with applause? Sorry, you're free to start with it.
Good morning. I am Lucky Sunshine Go, and this is Man Siren Sarmiento from the Philippines. And we will be presenting about our proposal, Project ARM, Antibiotic Resistance Mitigation and Education Dissemination. So according to the Philippines Department of Health, acute upper respiratory tract infection is the leading cause of morbidity and one of the prime contributors of antimicrobial resistance. However, due to the decentralized and fragmented healthcare system, majority of the low-income households, especially in the rural areas, cannot afford and access treatment in the hospitals and clinics which are mostly located in the urban areas. Because of this, self-medication has been chosen as a cheaper alternative for those who cannot afford the cost of treatment. As part of the survival strategy of the community, antibiotics were made available without prescription in roadside or sari-sari stores and unregistered drugstores, which often results to intake of the antibiotics in not clinically indicated patients. These contribute to antibiotic misuse and development of antibiotic-resistant strains in the country. On the other hand, many doctors are pressured to prescribe antibiotics to patients seeking consult to meet expectations. The patient's misconceptions on the use of antibiotics and the lack of awareness of the associated benefit and side effects have led to the demand in prescription for respiratory tract infections. As part of their sense of duty, doctors are compelled to provide support to their patients, resulting to overprescription. Efforts to raise awareness about antibiotic resistance have been made. However, Philippines, being a multilingual country, has coexistence of several unrelated languages under the same national roof. With the information campaigns predominantly written in English and Tagalog, few to none are catered to the other languages, making these efforts rather ineffective. With the increased availability and accessibility of antibiotics, inadequate knowledge and misconceptions of patients about antibiotic use, and increased pressure of doctors to prescribe antibiotics, there is a rampant misuse of antibiotics in cases of acute upper respiratory tract infections. So with this, our general objective aims to describe the misuse of antibiotics in acute upper respiratory tract infections, with specific objectives that aim to increase the knowledge of patients about antibiotics by health education and promotion of proper antibiotic use, to decrease the demands of patients and expectations on the antibiotic prescription by using the delayed prescription algorithm, and to decrease the provision of antibiotics by the informal sellers by delayed prescribing algorithm.
So to mitigate the rising antibiotic misuse in the country, our team proposed solutions focusing on the implementation of the delayed prescribing strategy in the management of the respiratory tract infection, and enhancement of patient education by using the local language as the medium of instruction. So first, we will develop an algorithm based on the NICE guideline for the delayed prescribing of antibiotic for URTI. The algorithm will look like this. Okay, so it will aid in the differentiation of the self-limiting viral URTI, bacterial upper respiratory tract infection, viral URTI that progressed to bacterial URTI, or diseases presenting URTI-like symptoms. And at the end, the algorithm will tell the patients to either wait until the resolution of symptoms, thus no consultation and antibiotic needed, or they need a consultation. In developing our algorithm, constant consultation with an infectious disease expert and community physicians will be done. This algorithm will be translated to local languages, and then it will be distributed and taught to the respective communities, targeting those with difficulty accessing healthcare services or far-flung areas. We will specifically target people who have low socioeconomic class, the community healthcare workers, and the roadside sari-sari store vendors of antibiotic. We will get help from the DOH or the Department of Health and the local government unit to identify these communities and for distribution as well. The second proposed solution is the information education and communication materials will be conceptualized with the help of infectious disease specialists. Topics will include upper respiratory tract infection and antimicrobial resistance in general. Again, the goal is for the people to differentiate viral and bacterial URTI and proper use of antibiotics.
5 minutes.
This will be translated to different local languages and will facilitate better understanding of the concepts, which can at times be abstract, especially to those who lack formal education. This will be disseminated to doctors and other healthcare providers in all municipalities and all healthcare facilities, and to the general population through the help of DOH and local government unit. We want to emphasize that this education dissemination part of our project is very vital for the success of the algorithm. How will the people appreciate the project if they don't know what it is for or what it is preventing to happen? So with the use of delayed antibiotic algorithm, there will be eventually an increase in the knowledge of the patients about antibiotic use in acute URTI, leading to decreased demand in antibiotics of patients. In addition, there will also be a decrease in unnecessary medical visits, which will then decrease pressure to the doctors to prescribe antibiotics. Furthermore, there will be an increase in knowledge of the informal sellers about AMR, resulting to decreased provision of antibiotics by these sellers. Through dissemination of IAC materials and translations of these materials to the local languages, we will eliminate the language barrier and increase health education and promotion of proper antibiotic use. Using the increased knowledge of patients about proper antibiotic use, misconceptions will be debunked and patient expectations will be decreased. Thus, we want to see a reduction in self-medication, medical visit, and overprescribing. Quarterly reports from the municipal health centers will be requested containing the following questions: number of times the videos have been played in the center and the amount of pamphlets that have been disseminated to the residents under their jurisdictions. Tracking of overseeing physicians given antibiotic prescriptions for RTIs will also be done. Over time, there should be a decrease in antibiotic prescriptions given as the extent of knowledge about antibiotic resistance and respiratory tract infections increases in the population. Furthermore, a survey question will be asked of the patients or visitors of the health center. The answers to the questions can be obtained from the video or other educational materials. So for the benefit of time, we will emphasize key points of our SWOT analysis. So first, the strength of the delayed prescribing algorithm is that it is tailored to the needs of the community. It can also be integrated in the national policy and can be used for other syndromes or diseases. For the translated IAC materials, they can be disseminated to a greater audience through the social media.
So by proposing Project ARM in the Philippines, we hope to give Filipinos a better chance of surviving the deleterious effects of antibiotic resistance and to live in a world where cure is still an option and not an impossibility. Thank you.
Thank you so much. All right, questions? Ma'am?
In your algorithm, you are targeting the antibiotic vendors. As in many places, antibiotics are one of the main income for these vendors. Do you think that you would have an impact to them decreasing their sales? Are they doing profit with that?
Okay, so is the question, I'm sorry, so the question was, are we expecting that the sellers, the sari-sari store sellers will decrease their sales? Well, yeah, basically, yes. But,
Let's talk to the judges.
well, yeah, basically that, our answer is yes.
So the question is how and why?
How and?
Why?
To kind of repeat the question if I had right, so like what's the incentive of the drug sellers to decrease their sales of antibiotics? Like how do you get the drug sellers on board with your project?
Okay, so the sellers, we know that antibiotic misuse is rampant in the Philippines. However, by proposing that they will be given the algorithm, we are hoping that their minds will be open. We will teach them the reason on why it is important to use the guidelines or the algorithm that we had given and the value of antibiotics in the future, so that we can prevent the antibiotic resistance. For their economic sales, we will try to give them to link them with the government units in the vicinity, wherein they can be given jobs, as well as provide necessary other educational means, wherein they themselves can promote antibiotic awareness and get jobs as well.
Thank you. All right. Was it Mark or Elizabeth? I think we'll start with Elizabeth.
So that was actually going to be my question, was about the incentive of the sellers. One thing to think about, and we can talk more about this later, is the possibility of, not to give you answers, but to think about something along the lines of an accreditation scheme for sellers for the future. But we can talk more about that in the future. But that could be a way around incentivizing. I think that's something that you haven't considered, but it's something that I think is a potential add-on for the
field project, how much money do you need?
Many zeros.
He's a rich man.
In terms of the development of the algorithm, I think it's going to be free. I mean, we will not, it will not be cost anything actually. More on the production of the educational materials such as videos and pamphlets and brochures and like posters. Actually, we already had similar project in the past. So we already did videos that was translated to different languages in the Philippines. We have an example right now. So it only cost around 5,000. So it's in pesos. So it's around $100 only. So yeah.
Thank you. We only have 30 seconds, so one quick question from
Sure. One question that I have is, while you were coming up with the concept, did you think of traditional practitioners? How are you going to get them involved if access to healthcare facilities are difficult, especially in the rural communities? Your first entry is with the traditional healers or practitioners. Did you think of how to engage them to get them on your side?
Unfortunately, we don't have time for the answer, but that's something for you to think about. You can answer. All right, can we give one more big applause? All right, next up we have Brian, USA. Ready? All right, let's go.
We are Team Prime, preventing resistant infections through monitoring, machine learning, and education. Our team is made up of 3 members.
My name is George. I'm based out of Washington.
I'm Gayatri Senku. I'm a PhD student at Georgetown studying immunology.
And I'm Katie Viverito. I'm a veterinary student at University of Illinois. So our agenda today, we're going to start off with context and challenges, and then we're going to move on to the priorities of Prime. We're going to go to platform components and our next steps, implementation plan, risk limitations, and our expected impact. So AMR challenges throughout the Southeast Asia region are pretty unique. There's inadequate antimicrobial resistance. A large part of this is due to poor clinical records and limited data. Informal healthcare providers provide a lot of the response to AMR, and antibiotics are widely available, often without prescriptions. Laboratory testing within the region is very limited, prevalent, especially in colonial and countries. There is a large growth of large-scale agriculture that has escalated within the region, and few countries report statistics. We have decided to concentrate within the Southeast Asian region on rural Vietnam to begin the implementation of our project. And that is due to the availability of healthcare settings within some of the larger cities within Vietnam.
So out of the context that we've identified, we see 3 priorities. The first is to target informal human and animal healthcare providers and give them access to the appropriate guidelines for antibiotic prescription. The second is to develop a cloud-based electronic record system for patients and antibiotic treatment history. This allows the informal healthcare providers to track their patients and gives us access to data on antibiotic use and treatment outcomes. And finally, we hope to apply machine learning algorithms on top of the data that we've collected to identify and characterize resistance patterns and identify risk factors for poor treatment outcomes. Together, we're calling this Prime. And these 3 priorities are targeted with 3 components of the Prime platform. Prime Guide provides offline resources as well as mHealth-based live support for care providers. Prime Watch collects data to improve care and bolster surveillance platforms. And Prime Predict harnesses machine learning algorithms to predict outbreaks and identify risk factors. So let's start with Prime Guide. Prime Guide has two components. The first is a set of offline resources based on international practice guidelines that are context appropriate and culturally adaptive. They're designed for care providers so that they have a reference to go to when they're faced with cases that they are certain about. Many of these informal health providers are practicing far out of scope, dispensing antibiotics in response to diseases that they see. We want to give them access to algorithms and practice guidelines that can help guide more rational use. In instances where there are more complex cases or where providers don't feel comfortable, we hope to give them access to infectious disease specialists in urban areas in Vietnam through remote guidance via text or call, as well as a social feed that gives them an ability to discuss, to train each other, to collaborate, and to share information about the context in which they're practicing. So the next steps for Prime Guide. We want to identify the stakeholders that are in the field. Who is interested in mHealth? Who is interested in improving access to information in rural areas of Vietnam? As well as reaching out to informal healthcare providers in key regions. We want to look into credentialing for care providers as an incentive for platform use. A lot of revenue is generated through sales, and consultation is usually not charged. And so how do we incentivize people to use this platform? For measure, we hope to measure app usage among care providers and to test the usability of the app interface. And finally, we want to assess the applicability of international care guidelines in the context in which these informal care providers are practicing. Prime Watch, as we mentioned, is a structured data collection platform that augments existing surveillance systems that often miss rural areas. It also, hopefully, will provide a dashboard of regional data based on the data that we've collected through structured case report forms. So for Prime Watch, we want to connect with public health stakeholders that are already collecting data on antimicrobial usage. We want to create a structured case report form in collaboration with local health systems and informal care providers to ensure that that case report form is usable, and reports data that is compatible with existing health systems in Vietnam. Finally, this is an expensive project, and so we want to look into potential funding sources to help us develop this platform.
The last stage of our intervention is Prime Predict. Prime Predict is going to be using machine learning algorithms to incorporate both epidemiological as well as microbiological data that is currently existing, as well as through our case report form database. This algorithm will be updated along with our hopeful partnerships within the region of Vietnam, as well as Southeast Asia as a whole. And we're hoping to develop a decision support tool for informal care providers.
I think that what we've sort of left out of the PowerPoint is that every part of this process is going to be iterative. And so for us, we haven't yet been able to identify sort of a rational timeline because there's so many stakeholder engagements, key informant interviews, sort of concept elicitation sessions that we need to go through to sort of scope out, what a pilot project would look like. And so I think that's a great question. That's one that we're really curious to answer, and that we hope to sort of formalize as we move forward.
And also to build off of that, I think that the three of us have taken on each a different side of this project. At Katie in One Health, myself in the microbiological side, Darby in policy and stakeholder side. We're hoping to capitalize on our respective backgrounds to make that timeline.
All right. Next question.
Yeah, I was looking at your Prime Guide, and you were going to be looking at integrating CDC guidelines and all that to your Prime Guide. I think what needs to happen really, because I've been developing guidelines all my life, I think that needs to be really very carefully thought of, because I don't think it needs to be a CDC guideline, but more a national Vietnamese guideline, because then if you want to sustain it, I think you need to really work out with the Vietnamese colleagues to really look at which guideline you need to be thinking about.
Absolutely. Yeah, I think that's an excellent point, and that's one that we've been very focused on. We want to use existing international guidelines as a base, and obviously work with Vietnamese stakeholders to adapt and to make sure that this is something that they can take and evolve further. That's definitely something that we're considering.
Thank you. Are there more questions?
third part with about the predict, you said that you will use it for decision making and something like that. Who will be the target for that? Would be the practitioners using the app, or would you share that information more broadly to health authorities or medical associations that they can update the guidance, which is also part of your cycle for prime guide?
Yeah, so we're hoping to target informal care providers for the initial stage of our intervention. And the reason that we're hoping to target this audience is because informal care providers in Vietnam are currently one of the main sources of weakness in the antibiotic pipeline and misuse of antibiotics. We also are considering the broader expansion of our of the results from this disease use tool to also include patients, because there has been some literature that's shown that including patients in this process has actually made them feel more comfortable with the decision outcomes that their providers provide. But we're still looking at this aspect. One thing I think that we did not mention is that we're also going to translate this into both Vietnamese as well as the local regional languages and dialects that are being spoken, to make it as culturally valid and useful as possible.
Thank you. Are there more questions? Ready a little bit. Anna?
Yeah, quick question. Your project is focused on rural health practitioners. Have you also thought about, since some of you are interested in the One Health approach, and in terms of agricultural practitioners and professionals, would something like this also be helpful to go beyond just human health practitioners?
Yeah, absolutely. And especially within the rural settings, we really hope to target, it's a little more difficult, right, because you don't have your informal care providers, it's more just livestock caretakers. So we do hope to look at antibiotic at least sales data and try to get preliminary information back from the guide to start targeting that audience. But ideally, we do want to extend it to the One Health aspect as much as possible.
And the challenge is, of course, that most of the antibiotic administration is from owners. And how do we incentivize owners, and how do we prevent scope creep with a project that's already quite challenging? So I think that's something that we've thought about, but that really is kind of tough to integrate, given the things that we've got going on already.
Thank you so much. That was fine. That was really fine. Thank you. We're all public health people and we like regulations, so the next one is a good one. It's bioregulation. Anishwa and Augusta, please. From Honduras and Anishwa from Pakistan. So just say when you're ready, sir. Great. But where's the applause? The clicker. Brian, did you steal it?
It should be on the page.
You can take it as well. Is it working? Okay. Good. All right.
Okay, let's go. Good morning, distinguished audience. Thrilled to be here sharing this moment with everyone here. We're the bioregulation team, composed by your current speaker, Augusta Baran from Honduras, and my partner, Nishwa Azim from Pakistan. And we're here to present you our project, BioTrack. So, before entering the details of our project, sometimes as a society, we forget or ignore that public health strategies are bilateral efforts, meaning that the community must involve itself in the efforts to create better health conditions for everyone. And the way to have this is through health empowerment. That being that awareness of the role and the responsibility that community plays in the dynamics of health. To reach this empowerment, we have to educate, and the keystone for education is communication. And so, when it comes to antibiotic usage, can we say that communication and health empowerment has been strong enough? Well, perhaps not so much. As we can see from the current graphic, antibiotic consumption has been high in the century. High-income countries, it has a point. high-income countries have presented a still big consumption, while low and middle-income countries have seen their usage spike within the last years or dramatically rise. According to the PNAS, on average, there has been a global increase of 65% in global antibiotic consumption. So, for the most frequently identification reminders will be present, we will introduce dynamic and interactive companions that will serve as the alarms. These companions will be varied. It could be animals, objects, memes for the general population, and customizable to a certain degree so they can much be easier marketed to different audiences as an option to administer the medications. So make it this way, we will make it harder for the consumer to ignore the alarms, as they will be linked to something emotionally charged because they like the dog, because they feel an affinity for whatever the avatar is, while at the same time keeping a record of everything. As public health activists, we do not have the time or resources to be constantly applying a survey on antibiotic usage to the general population. But almost everyone has a smartphone nowadays. So therefore, the secret catch and true purpose of the app is actually to collect community-level data, mostly from high-income countries and low and middle-income countries of the upper middle, who have more access to the internet, and also corresponds to those countries where antibiotics are used the most, making it a key target to provide with research material and data to help shape action and policies. Finally, the app will be able to offer standard guidelines and information on the compounds that help increase patient comprehension. So BioTrack communicates your prescription guidelines and educates you in appropriate medication taking habits, able to work as an individual or as a group entity to help you and everyone be healthier.
So very quickly talking about implementation. In any business or any enterprise, there are three things that need to be done. Number one, someone who can make it. Number two, someone who can market it and take it to the market for feedback. And number three, someone who can take care of the money to make it sustainable or to have generate profit. Next slide, please. In implementation, you have a software team which is a computer and a mobile software team, which uses very specific behavioral patterns which are already used in Silicon Valley to design algorithms, the reason why you edit it to your mobile phone, and have a very efficient stack which is like team. Next slide, please. Then we talk about implementation. Pharmaceutical companies who already have a vested interest in prolonging their lives of their current product sales. We have external stakeholders, which we have sitting here, who are providing grants and who are providing funds to work on antimicrobial resistance. And secondly, and thirdly, the government, which has to do a very basic cost-benefit analysis as to the investment in this and the economic burden of AMR. Next slide,
1 minute.
And then we have implementation where in the healthcare centers, this app has public value to provide services. And then the medical visits to diffuser, we have pharmaceutical companies which just need to attach BioTrack to the medication, and the PR team which leads to media and to spread that. Next slide, please.
Just you'll get 2 more seconds. Right, got just pausing out for a moment. This serves as a reminder for the AMR memes. We are still looking for AMR memes. Should 30 more seconds.
Yes, please. So this is a projection of the costs that exist. And this cost is very favorable for high-income countries, but even for low and middle-income countries, which might have an economic issue to it, we can have toned-down tags, which are gets the objective done, but are much cheaper. Next slide, please. In monitoring, we can monitor through professional quantifications of the tag, the demand, and the service, which give us the knowledge of how many people are using it and how they're using it. Next slide, please.
Thank you. Sorry, Mishra. I paused it, sorry. All right, next of questions. Anand?
Sorry, I've not understood how you manage the duration of treatment. Because the same antibiotic can be given different duration depending on the indication, things like that. And how the time You use a tag to identify the antibiotics, but how you identify the
So there are
dosation?
two ways that the tag can either be generated by the pharmaceutical with the medication, or it's something which can be available at the pharmacies at hand. So if it is produced by the pharmaceutical with the medication, you can scan the QR code, which gives you information of the name of the pharmacy, of the name of that, and according to the prescriptions, they can start off the days as to which they prescribed to. Does that answer your question?
Based on a prescription.
Yes.
Also, if they're not able to use the QR code or they are post-produced, there is the method out there which will have a specific code for any kind, for every single type of active compound and presentation. So in any case, the QR code does not include the information, the method will, and the app will be able to read that.
And another question linked to the duration. We know that in many places they cannot purchase the full course. Then they will go day by day at the pharmacy or wherever they can purchase the antibiotic. And so do you have a reminder also on the app to buy the antibiotic?
That's actually a very good idea. But I think because in our software we have given that feasibility to add on things as to demographic information. So you can add on an information and an option as to when you want next bio antibiotics, or your current prescription is valid for how many days. So that makes
All right. Any other questions?
Let me ask. So sorry if I misunderstood, but you're going to place that stuff on the box of antibiotics. So what is the incentives for the pharmaceutical companies to put that?
So I think as we can identify pharmaceutical companies, there are three things. Number one, that we believe that they have a vested interest in prolonging, like, the new business model and prolonging the life of their antibiotics that they're selling as to the money they have to invest into research. The second thing is that this project does not have any conflict of interest with the pharmaceutical, because this is a post-prescription intervention. And the third thing is if we want to hold them corporate and socially responsible. And the fourth thing, as a behavioral thing, if one pharmaceutical company is doing it, the other one wants to do it because of competition or because of the people's needs.
All right, thank you. Other questions? Anthony. Oh.
So tell us a little about the context and where you want to introduce it. What would be the suitable, optimal context for introducing this intervention? What type of country, what type of system to be best suited for receiving this intervention as a starting point?
Okay, BioTrack, or let's say the basic model of BioTrack, it will be most suitable for the high-income countries and the upper middle of the low and middle-income countries, because they will have more access to the technology and the resources to actually help fund a project like this one. However, we do have as well considered other options to be able to incorporate it in the lower middle of these countries. But the main target population will be the high-income countries and the upper middle of the low middle-income countries, because they are the ones who are consuming the most antibiotics so far.
Okay, so just to add on in the tag, we also have a software and an application which we're talking about. So we can also use that application for reminders, etc., and also to collect data on community level consumption of antibiotics, which we see has been more of a void in the information. So using that to make policies and etc. Is also something which we think is very interesting and serves the government and serves antimicrobial use.
All right, there's 1 more minute if we have any other questions. Anthony?
Have you considered how this might be piggybacked onto existing authentication technologies like mPedigree or PharmaSecure, whereby they in fact have already scratch-off codes, for example, on packaging, 1 billion packages in India alone, for example, which might help accelerate your introduction of this technology into such settings?
25 seconds, guys.
Actually, we did not consider that approach, and I think it's a valuable contribution to it actually. However, we do feel that if there is already a platform that we could introduce ourselves, we could use that pathway to use the pharmaceutical way to already incorporate this product within their mass production already. So it's a perfectly viable way that it would not have considered.
Thank you. Time's up. Let's give a big applause. All right. Next up, we have Andy Chu, biologics from China, Sichuan. 2018 and nobody's really invented technology that works.
It's antibiotics.
Yeah, quite secure. So we're really experiencing technical difficulties. Please bear with us for a moment. If somebody wants to sing, it's also fine.
Jonah, have you tried hitting it?
Yeah, but now the more. Get back to your seats, we are on. Yeah, so you can do another PowerPoint. This is the first screen. Yeah. Alright, thank you. Sorry for the wait, we're on now. Alright, so next once again, antibiotics from China. You're welcome to start when you're ready.
Good morning, ladies and gentlemen. Can everyone hear me okay in the back? Okay, so actually I'm correcting a little bit because our team name is Anti-Square Biotics and our proposal name is Cure Medicine. So we are all medical students from Sichuan University, West China Hospital, and this is our team members. I'm Xu Ying, the team leader, and this is Ji Jianrui. This is Shang Muyang. This is Zhang Yutian, and this is Wang Haoyuan. So we're very honored to be here. I'm gonna introduce this in 4 parts, starting with the context and all the way to the risks and challenges. So without further ado, let me welcome our team members to introduce something about the introduction of our proposal.
Okay, now let me show you some related background in China. First of all, the application without clear treatment targets and arbitrary application without etiology examination results and easy access to antibiotics makes a bad healthcare system in our country. At the same time, most people in China think the antibiotics can cure almost all disease, so they take the antibiotics as their first choice when they're ill. Like this. And the abuse in animal husbandry and agriculture industry also plays an important role in the confirmation of the AMR, like this. And based on the problem sheet we learned yesterday, we have these 3 codes, and our problem is the usage rate of antibiotics in the past 5 years in China has remained between 6-7% and 8-3%. So China has become one of the countries with the highest incidence of bacterial resistance in the world. And in China, the clinical application of antibiotics has are divided into 3 levels, and the right of the prescribed are limited to different levels of the doctors in the hospital. So, and the next part I want to show is the QR code, because the more and more use of the smartphone in our country, so the QR code is very universal in our country, and it has a lot of functions. Now let me show you the solution to our problem. We're actually creating a QR code based system by attaching a scannable QR code as exclusive identification for each package of antibiotics. And the system, which is named the QR medicine, is what we want to contain a database which could record and trace out the produce to consume process of the antibiotics. And if we have collected certain statistics, we can better estimate the use of antibiotics. And first, let's see our main elements. First one is QR code. And I have been here in Switzerland for 5 days, and in the past 5 days, I have never scanned any QR code. However, when I was in China, I scanned QR code almost 4 to 5 and more than that times a day, to pay for my bill, to add friends, to sign up for my classes, and yeah, it's really widespread. And second is a database. It's a good tool to store information about drugs, about patients, and multi-purpose accounts. Factory accounts, pharmacy accounts, doctor accounts, and patient accounts, which will be explained in details later. And actually, our purpose is to trace and standardize monitoring the helpful information of the flow of antibiotics. And to achieve this, we need a database to store data. However, we cannot connect to the database directly, so we need a client. And between the client and the database, there's a QR code. QR code is actually working like a bridge. And how does it work? The system QR medicine. It includes 4 steps. First one is the pharmaceutical factory. When a package of antibiotics is produced, a unique QR code will be designed automatically and attached to it. As soon as the QR code comes out, it can be updated to the database, which suggests that the antibiotics has entered the market officially. And next is about the pharmacy and hospital. After the antibiotics has been sold to the pharmacy or hospital, the QR code will be scanned there before entering the warehouse. Afterwards, new information like name of the hospital which the package of antibiotics flows into, times of arriving, etc. can be recorded and become traceable. And step 3 is the doctors. After making a prescription, including some antibiotics, the doctors need to log in the system to confirm identity and input information of the patients. And this is crucial in the 4th step. And then the database records information and authorize the right to prescribe of the doctor. And the final step is about patients. Before really purchase the antibiotics, the patient has to do 3 things before purchasing. The first is to sign in with personal accounts with his or her personal identification, and then scan the QR code on the drug package. And it will pass only if it's matching with the case report and the doctor's login before, and the database record information.
And then the patient have to learn antibiotics related knowledges and finish the quiz. Only if the quiz is finished and get to a certain grade can this patient buy the antibiotics. And maybe we can add something else like promotion informations and like a smart memo to remind the patients to take pills. So what's the innovation of our plan?
So what's the innovation in our proposal? Firstly, on new measures of managing the antibiotics, a special department of China, National Medical Products Administration, should be established before starting the project, in charge of monitoring the implementation of overall evaluation and improvement. And second, database. Database function as the brain of the whole system during all information. The database is to be established and run by the government, so the security of the information can be guaranteed. There will be also an app connected to the database, which is the window to read and write all the information. And third, each package of antibiotics is attached with a QR code designed automatically by the computer as a unique identification for it, which is realistic due to its uniqueness and the ability of QR codes to lead to certain e-page with numerous information. Fourth, tailor-made medical instruction, which is one of the most interesting things in our project. The knowledge of the drug, the disease, time and frequency of taking medicine, and other things needed to know can be recorded into the QR code. Special information can be added to by doctors to the patient. And how can we change the situation in a good way? Actually, to make it short, managing the whole life of antibiotics to reach the awareness of using antibiotics properly. And as for implementation, promotion, monitoring, it divided into 4 steps. Step 1, set organizational structure. And step 2, developing database. And trial operation.
Time's up. Thank you. An applause. Thank you. All right, questions? Hello?
Thank you so much. I'm not a millennial, so maybe you need to explain to me the concept of this doctor and the patient. How does that all interplay into all this QR code? Because that's the place where I am not sure, that the link between all of these.
Yeah, actually, we haven't finished the presentation yet, so we must explain it here. Actually, the QR code functions as a unique identification for each package of the QR code, which is the essence of our project, which means each package of antibiotic will have a different QR code to store its own information. Like, we can store the information from the factory to the drugstore and to the doctors, to the patients. As for the doctors can add some information of the patient to the QR code by scanning the QR code. So the whole process can be united as a union. And patients, by scanning the QR code, can learn the information from the factory to the doctor's advice within the QR code. Yes.
All right, Arne?
Thank you. This is interesting because this idea of tracking the flow of the medicines in the countries. Now I know, for example, Turkey have done a similar project a few years ago without the last part. That means at the patient level there is nothing, but they have put a system. Just for information, I think if I recall correctly, it took 5 years to implement because they have to work with the industry, they have to work with the wholesalers. We have not mentioned the wholesalers, but I think you need to know where the antibiotics are in warehouses or things like that. Then this step is also important. And the question is also, it's used also for quality control if there is problem with a batch of medicine, they can recall that they know exactly where they are, which pharmacy or hospital, who have used it. This is important, but just the cost for Turkey was very high to implement because they have to work with many actors.
Mark?
Now, if you return to China and we support this idea, who should you approach in China to make this happen? How does it work?
Our presentation, we have some resources we already have. For example, several years ago, we have published the administrative measures for the antibiotics use, which gives different levels of doctors different access to antibiotic drugs. For example, a resident can prescribe only basic antibiotics, while a chief doctor can have the access to all the antibiotics, and that's one of the resources we have. And also we have other resources like we have several database of hospitals and pharmacies. They already have their own database. Like in hospitals, they have electrical medical record to keep the lab test results and prescriptions, and in pharmacies they have database to keep their selling records. So we only need to do now is just to combine these databases and systems into one system, and also the scanning equipment and the wide use of smartphones and QR code is everywhere. So it's just an idea we need to put up with, and then it can just happen if there's a trial run in the city.
Yeah, but to who do you go?
Yeah, so adding that, I know there is a kind of concept competition called Eat Nice Plus. So we go back home and we file the proposal to that context, and we will be able to establish a conversation with the government, probably have winning the grant for the government from the government, and then we implement these things within the hospital. We have like a benchmark city to actually do this like test run, and then we spread it out the whole country. And this is like
10 seconds.
yeah, Somerset just is very complex because there are a lot of stakeholders, and we were wishing that government should probably have some technical help on that, and we are going to collaborate with the payment platform such as Alipay to.
Thank you. Time's up. Sorry. Thank you. Give it applause. Alright, so thank you, and the two biotics, and the square biotics. I was never good in math, so became a doctor. So the next team is online. As I explained in the beginning, we have 11 teams chosen as finalists. The next
I greet everyone on the panel, and I greet everyone seated. We are very unhappy that we are unable to make.
And the next team is called Global Health Enthusiasts, and they come from Nigeria. Due to unfortunate reasons with the visas, they could not get their visas, should be with us today. But luckily they've recorded a video and should be able to present their project in any case. And I understood that they're also available by Zoom, that is by Skype, for questions then after the presentation. All right, that's good.
Hello everyone, I greet everyone on the panel, and I greet everyone seated. We are very unhappy that we are unable to make this presentation in person, but against all odds, we're making this presentation to you. The introduction of the team members. Our team is the Global Health Enthusiast team, and as shown on the board, the team members are Adebisi Yusuf Adebayo, Bamshai Adela Washe, Olai Amila Kazin, Olatunde Olayo. I am Olatunde Olayo. This is a picture of the team members. Our project title is Smart Antibiotics Purchase Authorization Card, the SAPA card. In Nigeria, prescription monitoring is poorly conducted, and prescription-only medicines, POM, including antimicrobials, are routinely sold over the counter by the patent proprietary medicine vendors, also known as the PPMs and drug the sale of the prescription-only medicine, including antimicrobials and over-the-counter medication, is unlawful. PPMBs in Nigeria and in many developing nations still sell these medications over the counter. Yeah. As shown on the screen, this is a picture of the patent proprietary medicine vendors and drug vendors. This is another picture of a street vendor.
I am Alexis Sualebayo. I am Olaomi Dananda cousin. Context and background on the specific intervention funds or pathways chosen. In developing countries like Nigeria, one of the major issues that has to do with antimicrobial resistance is the availability of antimicrobials without prescription to patients that are not even in need of the drug. But he has provided innovative ideas to successfully take antibiotics off the hands of PPMs and still make them relevant in rendering related services to patients in urban areas and rural areas. The process supply chain of antibiotics in Nigeria goes thus: from the manufacturer to the distributor, then the retailer. The retailer in this sense consists of the pharmacist and the PPM, from whom antibiotics are gotten. We then propose a solution that tends to cut out PPMs from having access to antibiotics in Nigeria. PPMs are known to have little or no knowledge about the prescription or dispensing of antibiotics. So it is further necessary to cut off these PPMs from the supply chain of antibiotics in Nigeria if the issue of antibiotic resistance is going to be called in the country. Hence, we propose a central antibiotic store where all the antibiotics produced by different drug companies will be stored and ready for sale, from which network of distributors can come together to help in dispatch of the antibiotics. This will limit the access of PPMBs to these antibiotics. However, the role of PPMBs cannot be de-emphasized in rendering healthcare services. This central antibiotic store class will be situated in 6 geographical zones in the country. Ordering of the antibiotic will be strictly online through the central antibiotic store website, CAS website, where the pharmacist or the organized healthcare professional can easily order an antibiotic online, in which the PPMs will not be able to do that because of their low level of education and their ability to operate or fabricate the concept of what we introduced, which is referred to as the smart antibiotic purchase authorization card. The card will be given to all the pharmacists and the healthcare professional that will be the custodian of antibiotics, therefore cut out the PPMs, public supply chain. This is the prototype of the SAPA card. And this is the prototype of the SAPA card. The proposed smart card will be completed with identification alphanumeric system characters. These system characters will be unique to a particular pharmacist or the healthcare professional. And the card, smart card, will also contain the name of the pharmacist or the healthcare professional, as the case may be. And the expiry date of the card will also be on the smart card. This card will only be made available to the pharmacist or the healthcare professional, and PPM will not be able to have access to the card because they are not registered to even have the card. Ordering of antibiotics will strictly be online through the proposed website www.antibioticpurchase.com. The ordering will be made online by the pharmacist or the healthcare professional by inputting 16 alphanumerical characters that will be imprinted on the SAPA card. The ordering will be made with the PIN, and the pharmacist or the healthcare professional will have a unique password that is attributed to each card. This mechanism is basically like ATM or AMS of SAPA card. We propose the use of antibiotics registers with pharmacists, both retailers and pharmacists. This antibiotics register will contain the amount of antibiotics sold in the pharmacy and the prescription used in purchasing this medication, which must be retained for proper record of the antibiotics sold. Also, this was help regulatory pharmacists to track irregular and unauthorized dispatch of antibiotics in pharmacies. Also, antibiotics must tell the number of procured with evidence of purchase from the pharmacy, which means sales recorded must carry the amount supplied by the central store. Hence, regulatory pharmacy can have a proper audit of the total pool of antibiotics are likely to be poison used in industries, where all poisons used in production are recorded and can be traced at the end of production.
the SAPA card needed for the implementation of this project are designed such that information can be traced from both the card reader and the card itself to ensure that the amount of antibiotics dispensed are properly tracked. We need a website developer. This is the website where antibiotic orders will be placed. After these things have been put in place, proper partnership with the Pharmaceutical Council of Nigeria and the Nigerian Medical Association, NMA, will be done to ensure that the implementation is done such that only authorized personnel, pharmacists, and other healthcare professionals are authorized are issued this card and they are educated on how to use this in ordering the antibiotics. Also, pharmaceutical companies that are involved in producing antibiotics or that distribute antibiotics to Nigeria will have to be partnered with, and policies will be made such that every of the antibiotics is distributed to the central antibiotic store. From there, this will be distributed to every other person that makes an order online for antibiotics. Also, the government will have a major role to play in this in ensuring that these policies are appropriately instituted and implemented. The PPMBs will also be educated more on the need on the dispensing of antibiotics. This will ensure that when there is a case that needs antibiotics, they have the right knowledge to refer to the pharmacist or to the healthcare setting where antibiotics will properly be and education associated with this project. So far, no leaks has been identified yet. However, certain limitations are associated with this project. One of it is the fact that there's restricted access to antibiotics. However, this is a restriction in a good manner because it ensures that the use of antibiotics are optimized. Since our time with antibiotics are running out, we cannot afford to allow antibiotics to be accessible to just anybody. Also, there will be need for increased documentation. Paperwork at the pharmacies where antibiotics are dispensed, and also at hospitals where antibiotics are dispensed. Also, documentation from the softwares online, from the data gathered online from the ordering and distribution. Another limitation associated with our project is the fact that only the supply chain of antibiotics is actually being strengthened and patient compliance is not being attended to. This can be supplemented by increased education of patients on how important it is to complete their dose of antibiotics and to adhere to dosage regimen. Also, in rural areas where there are few to no pharmacists present, there has to be an alternative to access of antibiotics. This means that we might have to institute specialized centers for antibiotic distribution in rural areas because usually in Nigeria, there are few or no pharmacies in rural areas. And since we don't want PPMBs to have access to these antibiotics, this means that the rural areas will suffer from a restricted access to antibiotics. However, this problem can be solved by ensuring that there's a standard center where antibiotics will be distributed in rural areas. It is expected to strengthen the supply chain of antibiotics in Nigeria, which is very essential in ensuring that antibiotics are properly used and conserved, since we have little time left to antibiotics. Dr. Max Sprenger, members of the panel, our judges, and every other finalist of the Innovate4AMR Challenge. We look forward to meeting you in person and to our future collaborations. Thank you.
All right, let's see if we can get the Zoom to work. We see them. Hello. Do you hear us?
So they might be able to hear the questions if judges have questions because I have them connected on here. If other people have questions, let me know and I'll send them. Sorry, it's a little bit complicated with the audio.
You should be able to hear.
Yeah, if they answer questions, we can.
Did they know they're online? Yeah? Can you hear us? hear us now?
They can be the judges. We have something on the laptop.
Turn them. Mute the Okay.
Hello, so, okay, you can hear us?
Yeah.
Okay. So, I'm one of the, sorry, there's a lot of Okay, so I'm one of the judges. The question. So my question is, so you have great chances in action of antibiotics in Nigeria as well. What about if, for the purpose of private pharmacists try to go around this and purchase antibiotics illegally, for example, from countries around Nigeria? Is this I think it's a possibility, and what can be done against this? Couldn't hear me?
I'll collect the questions and send it to them. Sorry.
Can you hear us? Can you hear us? I think we'll do so we collect them and we'll have them 5 minutes at the end. Can you? So we'll continue with the presentations. And we'll have the 5 minutes for the questions.
Mark wanted to signal.
Mark?
So if you can, maybe send the questions to them.
Yeah, we're going to do so that we're going to send the questions to them.
Okay. So what I would like to know, this sounds very promising, but what do they consider as the most, let's say, difficult obstacle, and how to overcome that obstacle in order to make it a success?
Virginie, I'm writing the question now.
Okay.
Sure. So the question was, what do you think is the biggest obstacle in implementing protocol? All right, other questions? All right, other?
One is a clarification. Would this card be used only in terms of patients engaged card also be required to secure drugs at the healthcare center, which is, I'm assuming, is free in most of these places. So one is the clarification. The second point is about this sort of a silo approach. If you start having a specific card for antibiotics, what is next? Are there other models for other critical drugs that have to be conserved in this way? Yeah. Is that the right approach?
All right, other questions? Elizabeth?
I would be interested to know what type of incentives they would have for pharmacists to not turn to the black market, to kind of the flourishing informal markets.
Black market in terms of buying drugs or?
Yes. I think particularly in that region in West Africa, there's very flourishing informal markets, and when there's so many hurdles to have to purchase antibiotics, and when an individual comes to them and they really, really want an antibiotic, and they want it immediately, and they really, really want it immediately, and they're willing to pay a little bit extra. I believe Nigeria is known as a culture where they're willing to pay a little bit extra. I think West Africa in general is a place where people can sometimes pay a little bit extra to get something faster. We'll call it an efficiency fee. When you have cases where there's an efficiency fee, people turn to informal markets. So I'm curious how they'll get around, how they'll incentivize pharmacists to not turn to informal markets and really use the card and really use these superstores.
Okay. All right. Other questions? Arden?
I don't know if it's a question, it's just that they are putting new things in the supply of medicines, and also some of their projects is more general comments that how far they have discussed or they know about the regulations, because they will have to go through changes in the regulation of supply or sales of antibiotics. And I don't know, they have to change the legislation on regulation, then it's a big thing.
So it's a bit of a, like, you mean that it's a complex project and you're wondering?
Yeah, all these projects touching the supply of medicines, antibiotics, tracking that, and how to deliver or to sell, needs to adapt the existing regulations. And they need to have the buy-in of the Ministry of Health. And they cannot work without the authorities.
Sure. All right, thank you. So I think we have 4 questions now, which is approximately 1 minute to answer. So I think it's 5 minutes now. All right, so we'll send the questions forward, and we will hear their answers once we know for sure that we'll get the technology to work. So, all right, but next off we have
Indian Alliance for AMR.
our one-man alliance. Hassi, please.
Basically, we are going to implement a model which is entitled as APHI, Antimicrobial Prevention Hospital Initiative. But before that, it is important to understand why AMR is a problem statement in India. This is a very important thing which I should give a highlight on. So these are some statistical figures which are really staggering. If you consider, there are around 400 410,000 children below 5 years of age which are dying of pneumonia. And if you consider infectious diseases, there are around 417 people out of 100,000 that are suffering from infectious diseases. If you consider MRSA, in the span of around 6 years, there have been increased from 29% to 47%. And in a multi-center study conducted in 7 tertiary center hospitals back in India, they found that the ECBL producing antibacteriaceae, they were amounting to around 61%. These are the antibiotic consumption that I will be dealing with in further slides. So another important staggering figure is that 30% of neonatal sepsis deaths, they are attributable to antibiotic resistance. So AMR is a very grave issue in India. And apart in terms of, if you consider the awareness of the people, we belong to a sort of rural economy, agricultural-based economy. So this model is basically is something which is a very practical, something which is related to the ground reality. So 75% of Indians, they are not aware of the fact that there is no role of antibiotics in cold and flu. And around 58% of the people, only they know that we have to complete the entire course of antibiotics. Rest 42% are unaware of this fact. If you consider the antibiotic sales in India, it increased from 2645 triple D, that is defined daily doses, to 4950 in a span of 5 years. This rate is exponential. But if you consider the per capita consumption of antibiotics, that is a bit low as far as the higher income state economies are concerned. But still, we are lagging far behind in terms of infection prevention and control strategies, in terms of awareness. I've taken 2 prototype organisms. One is the E. coli from the gram-negative area, and one the Staph aureus from the gram-positive. If you consider E. coli, you can clearly see a big red zone area in India, and that is amounting to 80 to 100% of resistance to ECBLs. And if you consider the red part which I have highlighted here, if you consider the 9% resistance have increased to 15% in a span of around 7 years, and the isolates which were tested is 55 and then 3108, and this red is basically the carbapenems. Now considering the Staph aureus. The Staph aureus is not a very red zone in India, but still it is amounting to 40 to 59% of resistance. Now, if you consider any of the antimicrobials, like for example, if you consider, like say, aminoglycosides, from 2008 to 2014, the resistance percentage have increased from 24% to 46%, and the isolates tested have also increased. And if you see 2015, this is a very staggering figure that I want to highlight, is that there is 1% resistance to linezolid, which is basically a reserve group of antibiotic, around 105 isolates tested. So linezolid resistance Staph aureus have been found in India also. Now coming back to my own hospital, where I'm going to implement this APHI model, and then I'll be further scaling this up. I did a study back in September only, for a month of only 1 month. What I found is, I did for Staph aureus and E. coli. So what I found, 190 strains were positive for Staph aureus, and out of this 190, after conducting the antibiotic sensitivity testing, it was found on an average that 57.73% resistance were found among 190 strains. An individual antibiotic resistance I have also collected. There is no vancomycin in my hospital setting. Vancomycin resistance, DRS is not there in my hospital setting. If you consider this is just for a month of September, just to analyze a particular trend. And for E. coli, out of 76 total positive cultures, what I have considered 74.26% average resistance has been found. And more so, AMR in India has been the focal point if you consider NDM1, which originated from India and then spread to the entire world. So AMR is really a focal point in India, and this model basically deals with the ground reality. So it is important that we innovate for AMR. We all are here, and it is important why this picture I have highlighted. It is important for all of us to globally take some initiative and work upon, which we are here for. So what APHI model is all about? The goals are, first, the appropriate use of antibiotics, limiting the reserve group and the irrational FBCs. Second, enhancing the IPC and WASH strategies, which is very important as far as the Indian setup is concerned in our resource-limited hospital setting. Thirdly, increasing the understanding and awareness of AMR among the health professional and the community itself. And fourth, after the implementation of this model, APHI, in my hospital setting, we will have 25, what we have predicted, we will be having 25 AMR champions. And we'll be using them to implement this sustainable model to different zones of India also. So what we will be doing? We will be doing a baseline assessment first. In baseline assessment, we will be doing a CAP survey, like WHO is having different questionnaires for different topics. But I guess, to my knowledge, there's no fixed questionnaire for the AMR still. But what I have done, I will be doing a CAP survey which is based on knowledge, attitude and practice for the healthcare professionals that are in directly contact with the patient, that is the people sitting in, doctors sitting in OPDs. Then we'll be doing a sales monitoring, and then we will be doing prescription analysis also. Lastly, we'll be doing a hospital assessment for IPC strategies. This we'll be doing for a period of 3 months. This is the baseline assessment that we'll be doing. After baseline assessment, we'll be focused intervention. We'll be doing a focused intervention. In focused intervention, this is basically the AMR training of doctors, nurses, pharmacists, and community itself. So basically, a training will be done, and after training, we will be having a peer-to-peer training for the further medical professionals in different departments and wards. Then after baseline assessment, focused intervention will be of 6 months. Then we'll be doing an impact evaluation of this APHI model in our hospital. Then, with the necessary funding and other resources, we'll be doing a scale-up to different zones in India. So this is the timeline: 3 months for baseline, 6 months for focused intervention, 3 months for impact evaluation, and then further scale-up. So baseline assessment. First is the CAP that I want to highlight. I created a questionnaire. This sort of questionnaire will be asked for assessing the knowledge of the medical professional. Are they aware of the reserve group of antibiotics that they are prescribing? Are they aware that what sort of patient compliance is required? So these sort of questions we will be highlighting. Are they aware of the Red Line initiative? As far as the attitude, there are certain questions that I will be raising points on attitude of the medical professionals, and then certain points on the practice. We will be doing a pre-test, we will be doing a pro-test. So comparative analysis will be done. One is the baseline. Initially we will be in the baseline, and after that after focused intervention, we will be again doing this post-test. Now coming to the monitoring the antibiotic sales. As far as sales are concerned, we will be considering the biggest pharmaceutical stores in Aligarh. And to your knowledge, Aligarh is having a population of around 3.8 million, which is a huge population. So we will be doing the antibiotic sales monitoring, and what we will be doing is we will be considering the sales as a proxy for the chart audits, and thus we will be creating a metric scale, access but not access. So we will be analyzing the underuse as well as the overuse of the antibiotics, and with that, after plotting that, we will be creating hotspots in our locality of Uttar Pradesh, which can accommodate around 5 countries, I guess. We will be doing we'll be plotting the areas, we'll be finding hotspots, and then we'll be intervening in those areas also. Lastly, thirdly, we'll be doing antiviral prescription, as I told you. We'll be considering the irrational FDCs that are being prescribed and the reserve group of drugs that are being prescribed at the outpatient departments of surgery and medicine and the intensive care units, and for the dental section, as Dr. Mark said in his early lecture, that dentistry is something where AMR is really very much exploited. And I've read some papers also. So, with this, we will be categorizing the drugs into access, watch, and reserve groups. Now, what we'll be introducing something innovation. What innovation we are being including is that we will be including the Thailand model that Dr. Mark told us in the early lecture. We will be introducing the concept of delay prescription, and that we'll be implementing in our model 2. This is the clip that I published in Newsclick regarding the AMR crisis, overuse, misuse, and irrational use of the FDCs in August. Now, lastly, we'll be assessing the IPC facilities at the hospital. For IPC facility, we'll be doing a gap assessment, and we'll be dealing with hand hygiene, personal protective equipment, injection safety, and biomedical waste management. These are the 4 things that we'll be dealing at our hospital level. Now, we'll be dealing with things that directly affect the lives of the people. So we'll be dealing with central line infections, SSI, the surgical site infections, and ventilator-associated pneumonias in our hospital setup. And we are planning to promote a Safe Life campaign. Like we are promoting to save around 1,000 lives in a span of 1 year by including all different hospitals from different zones of India and with their collaborations. Like we have collaborated with CMC Vellore in South and EIGRMS in Shillong, which is located in the East. So they have agreed, and most probably will be implementing this model. So why IPC is important? I just want to highlight the first point that if 100 patients are hospitalized, and out of 100, 10% in LMICs, they face hospital-acquired infections. So IPC is something which is a very great issue.
Sorry, time's out. Time's out, sorry. No, sorry, time's out. All right, time for questions.
So maybe
All right,
here you said that you're going to be, your intervention is the hospital-based, right? And looking at all this prescription and maybe making sure that the therapeutic committee is also involved in that department. But I wasn't sure what is the connection of your intervention with the pharmacy sale? Because your pharmacy sale is more than just your hospital prescription. The pharmacy can also look at the community level. So I cannot see the link between those two.
Yeah, this model will be initiated, but for the pharmacy sales, I have mentioned there also, that we will be monitoring the large pharmaceutical stores, around 5 pharmaceutical stores in the district. And there are 2 pharmaceutical stores that are linked to our hospital. So in this manner, we can coordinate with them.
All right, thank you. Other questions? Arne?
Yes. Again, with this pharmacy sales outside the hospital, and indeed, if you can differentiate what is used inside the hospital versus what is used outside the hospital. And just for me, also, I don't understand for your intervention. Is it just to link with the rates, to try to link the consumption with
The consumption basically will be aiming at the OTC sales. Over the counter sales, where there is no linking of the doctor. Directly, the people who are unaware, they directly go to the pharmaceutical stores and they are prescribed. So OTC sales will be monitoring. And we will be monitoring what doctors have prescribed and what patients, whether patients are going to the pharmaceutical stores. Because in the manner, we'll be doing in a manner, the doctor, like ex-doctor, will be saying that these number of patients, they have been allotted by pharmaceutical stores. So they will be going to that by pharmaceutical store, and we will be analyzing whether they have taken that antibiotic or not, or they have taken, or they have taken, they have taken or not. This will be analyzed.
just to clarify, then you will use it's patient level data.
Yeah.
What they are prescribed and what they purchase.
Both the patient level data as well as over the counter sales where doctor is bridged.
All right, Arna?
Yeah, quick question. In fact, your very first point. Is a lot of that aligned with underuse rather than overuse?
Yeah.
So, in that sense, what would be your recommendation or solution? Because a lot of the discussion is on overuse, whereas we have seen in most of the low and middle income countries, underuse and access to basic antibiotics kills a lot more children than anything we've discussed. So, what would be your solution in Aligarh to deal with that?
So, basically, in Aligarh, if you see those patients who are belong to the rural setting, they are unable to get access to the antibiotics, and this leads to their underuse. So, first, accessibility issue is the major issue. And lack of access is causing various underuse of antibiotics in our setup. Then, we have to strengthen the primary health centers also. Primary health centers, the CHCs and the sub-centers, so that the antibiotics which are there in the tertiary center, they should have a proper flow up to the villages which are dealing with the sub-centers. This we have to check in.
Thank you. Other questions? Arne?
Sorry, again, for me to understand, again, with the pharmacies, are you looking at outpatient use? I mean, the patient that go for outpatient visit in the hospital? Okay, it's not inpatient?
No, outpatient.
Outpatient, going to the hospital for...
Outpatient and surgery and medicine.
Thank you, Anthony.
Can you say a little bit more about who's behind this and what your connections might be to actually implement this?
Yeah, this model I'll be using my mentor's assistance as a part of PHM India and represented antibiotic resistance coalition.
PHM is?
Yeah, PHM is People's Health Movement, which is an active organization working back in India. And so my mentor was part of PHM India and he represented ARC, AMR in Delhi 3 months back, I guess. And we'll be using the organization, we'll be using the support and assistance of GSS, which is the Jan Swasthya Abhiyan in back in India, and other civil society organizations which are working on AMR.
Right, thank you. Thank you, Anthony. have safer informality from Canada. So if I take a disc, please. There's the appointment. Sorry, when you asked the question, I thought you meant like anything. Are you free to start with
Hello everyone, my name is Pratik Sharma. I'm a graduate student of immunology at the University of British Columbia. My background is in antibiotic use surveillance, but it's from Canada, which is a high income country. And to better deliver an intervention in low resource settings, I partnered with
Jessica. I'm also a PhD student at UBC. I'm not in the area of AMR, but I've done some work with mobile health units in South Africa and also with informal communities in India. So needless to say, I'm really happy to be here to discuss about this idea of safer informality in West Bengal.
So one phrase to summarize clinical antibiotic stewardship is the right drug by the right route at the right dose for the right time. But in low resource settings, sometimes it's difficult to get any drug, and sometimes there are barriers to getting the right drug. That's why access matters for antibiotic stewardship, and we have to balance that with the issue of excellence. And one setting where this is especially important is in India, where in 2015 they saw the largest growth in the use of antibiotics, yet in their National Action Plan on Antimicrobial Resistance, they highlight the issues that Indians face in access to antibiotics. This is most severe in the rural settings. And this is worsened by the lack of access to trained medical doctors. So up to 70% of rural care is provided by private and untrained individuals, informal private providers.
So let's zoom in the area of West Bengal. And we're doing this because we found a study by Gosno in 2014 where they provided general medical training to informal private providers, and they documented some of their practices. And one of the things they found was that over 70% of standardized patient interaction resulted in prescriptions of unnecessary or harmful medicines. And what they also found was that 33% of angina and asthma-only patients were obviously inappropriately prescribed antibiotics. And so given the linkage with the informal community and also with some of the study findings, we thought that there was here an AMS opportunity with IPPs. And so the focal problem, or to frame the focal problem here, is that there's a suboptimal use of antibiotics provided by informal private providers in rural India. And specifically, we would like to focus on the community level. So before we describe our intervention, let's talk about some of our motivations. We did not want to start with an intervention from scratch. We actually wanted to work with Liver Foundation off of existing interventions, and they've already partnered with over 300 IPPs. And so we felt that this was a suitable, feasible option. And furthermore, we decided to do harm reduction methods because this has been not only a very pragmatic and achievable approach for a resource-scarce setting in India, but also we've seen that there's success in our own city in Vancouver with the opioid overdose, and also here in Switzerland there's a lot of supervised injection sites. And so given that, we think this is a feasible option, and also we would like to improve some of the intervention gaps that we found with the study finding. And one of them being that there's a lack of evidence on community stewardship. And one of the bigger gaps was that a lot of the IPPs in the previous study did not attend, there was poor attendance. And we think one of them, or we know one of them, is because of the distance to train.
So we used the problem tree to help identify solutions to our focal problem, which is the suboptimal use of antibiotics provided by informal private providers. The effects of this is that it promotes antibiotic resistance, it increases unnecessary health spending, especially that out of pocket, and it continues to mislead patients about the appropriate and correct use of antibiotics. We see three causes for this: a lack of trained MDs in rural areas, which is what the Liver Foundation's previous intervention was about, the distance to public and primary healthcare centers, and the fact that these IPPs operate in a legal gray zone, and thus formal settings or formal stakeholders are often hesitant to work with them and don't engage them in stewardship. So we then use an objective tree to to identify the components of our solution. So our overall objective is to reduce patient exposure to unsafe antibiotic prescribing practices, and we will do that by training IPPs to become effective and consistent antibiotic stewards. There will be two components of our intervention: mobile training units to help increase our reach and improve attendance, and antibiotic stewardship messaging. And there will be two outcomes for both components, and I want to emphasize that our goal is to measure effectiveness and consistency. And for that, we will do a rigorous quantitative analysis, the interrupted time design. So specifically with our antimicrobial specific training, we'll provide tailored messaging. We have to recognize that these informal private providers don't have a high level of education on it. So we have to make it content specific and have to tell them which conditions that they can potentially withhold antibiotics for safe. We also have to recognize that there are behavioral conditions in these antibiotic prescribing decisions. These are often working in small communities, and they can't afford to run afoul of them. And there are patient demands, so we have to teach them how to appropriately handle those situations.
And critical to our approach is ensuring key partnerships to understand who are the champions in the community. And we've identified the obvious ones like the Liver Foundation and the West Bengalese communities, but also we think that the Ministry of Health is really key in this process. And the reason why we think there's going to be strong buy-in is because right after the Liver Foundation produced their report, we also found the Ministry of Health had produced their own report saying that they would like to expand this to over 100,000 informal providers in the next 5 to 10 years. So they want to do that as partnership with informal providers. And furthermore, we also acknowledge that there are local champions, such as community and religious leaders that we'll partner with, and also REACT Asia Pacific, who has a mandate to do community stewardship, and also Save the Children, who has done some mobile health units in India. But key to this is that, key to this partnership and team formation is what Leach and Stones call the slow race to citizen solution. And the premise of this is that we want to do a bottom-up participatory approach because we recognize that they're the local importance, and that the West Bengalese people are not just passive beneficiaries in this process, but they're involved in the upstream choice and delivery, and also the downstream delivery and implementation.
So for our IPP recruitment, we have a relatively short period of 2 months. That's because the Ministry of Health is already doing this intervention, and the Liver Foundation has already engaged previously. And currently, we'll do a situational analysis that the London School of Hygiene and Tropical Medicine has already conducted, and we'll be asking them additional questions on the informal private providers' needs and their baseline knowledge about antibiotics. We'll use those findings to conduct a pilot and iterate over our proposed intervention, and for the next 18 months, execute this intervention. Then we'll follow up with informal private providers, the Ministry of Health, community leaders, and produce a report for general dissemination. And no intervention is perfect, and it's unfortunate to say ours is no exception. So on our reliance with the Liver Foundation, it proves its feasibility, but if we aren't unable to get them as partners, that is a potential barrier. That's why we spend so much time in our timeline for partnership development and demonstrate the alignment of our values and goals. Additionally, our overall objective was to reduce patient exposure to unsafe antibiotic practices, yet we don't report any patient-reported outcomes. That's, for example, if we reduce the antibiotic use, are there more hospitalizations? Because of the rural healthcare infrastructure, it's hard for us to get that data accurately, and to reduce the costs, we use these surrogates. But let's not forget about the strengths of our intervention.
So let me summarize the key points to our project here. And I'm going to summarize our safer informality with 4S. So first of all, we really focused on community stewardship because we feel that this bottom-up participatory approach will ensure that the local community actually becomes a resource rather than a victim. And by building on existing pioneering work, we believe that this will ensure the project is more feasible, and that our goal is actually to become facilitators of this project and actually to strengthen the existing infrastructure so that the local Bengalese people can actually carry on this project after its completion. And furthermore, we're going to ensure that we are flexible in this process, that it is an iterative process, so that we can consider the local context at every step of the process. And finally, we also think that by ensuring local and national policy coherence, that we're also ensuring sustainability in our project and also forward thinking. So to conclude, thank you, and we hope you join us in bridging the formal and informal and making safer informality in West Bengal and beyond.
Right, questions?
Thank you so much. For this, I think the community stewardship is really a great idea. And now I think, how would you then measure your impact, or how would you measure your effect in this intervention? Because how will you attribute what you're doing to what is going to happen in this, to change behavior within the community itself?
So the Liver Foundation, in their previous intervention, used to use standardized patients. So, you know, people have favorite ministry patients encounters, similar to that. So we'll send patients that are trained actors that will present with an uncomplicated diarrhea and see whether that encounter results in an inappropriate antibiotic. Additionally, patients can ask or will mention that they have leftover antibiotics that they will use. And if the product providers will start a conversation about whether that's inappropriate or not. So those are two things that we'll measure monthly in a randomized scheme, and then assess the changes in trends with the intra-country analysis.
All right, thank you. More questions?
I think, again, have you taken the economic considerations that asking the private providers to increase their sales?
Okay, so, I mean, of course, with the informal product providers, you have to recognize that they have a financial self-interest in selling the antibiotics. But people don't always act to promote their self-use. If they recognize that there is a harm that they're presenting to the community, these antibiotics aren't benign. So if they recognize potentially that they're actually harming the community, and if they feel that they're a strong member of it, they might be avoiding to do that. But we also remember that we're going to be training them, so they'll believe that they'll have more business by having these training accreditation programs. So hopefully that's one of the rationale for them to continue decreasing antibiotic use, because they'll have more patients coming for other concerns.
And it was actually studied at the Liver Foundation. So based off the first study, they actually saw that a lot of them said that their businesses increased because it felt like an accreditation system. They were a part of the system, and there was a trust that was built, and that financial incentive, I think, is pivotal to this work.
Thank you.
Yeah. Any idea of the cost for this study?
It's a small amount of $300,000 in their proposal.
Yeah, I mean, I think this is something we would work with actually people that know how to budget.
Yeah.
We're researchers, but I think obviously that idea is that we try to put together some estimated costs of hiring, research associates, making sure we have a key member from the Ministry of Health, and so that's actually sustainable after. But the actual economics behind it, and we're going to leave it to the experts. But I think the great part of this is leapfrogging and actually building on the existing intervention. So it's already been happening, and the Ministry of Health is already wanting to expand this and actually build it with 100,000 informal providers. Okay. So the initiatives are there, and what we want to do is really highlight that AMS component and put a lens.
So the mobile units are already available?
Yeah, so Save the Children have already employed some mobile health units in the area, which is why, again, we're working with existing infrastructure, but putting that other lens to it.
And there are a plethora of funding sources for this. So when they're trying to expand to 100,000 people, in India there's a rural health plan that is coming from the federal government that the states use. And we could also use Pfizer, it's called an unrestricted educational grant. And I think if you remember in Tanzania, the Management Sciences for Health implemented an accredited drug dispensing outlet program, and they use welcome trust funding. So we'll be looking into those potential sources for intervention.
And of course, any of your network.
And yes.
Feel
free to donate.
Yeah, we'll ask for money by the exit. 40 seconds. Any quick questions? No. All right, thank you.
Thank you very much.
Sure, okay, thanks. We're actually also having a session tomorrow on fundraising and business planning. So that's also for the future to kind of help our teams in kind of developing the needed tools for implementation. Moving forward. All right, so next off, the boys are here. So we have the team from Makerere University Medical Students Association, Uganda. David Nelson, please.
Yeah, thank you. Hi everyone. I'm Nelson Navasco, and my colleague is David Kazi. We are from Uganda. Well, our project is about increasing knowledge and awareness about antimicrobial resistance among secondary school students in Kampala, Uganda. Well, a little insight on the education system of Uganda. We have 5 levels of education. The first one is nursery school, whereby kids can start at 3 or 5 years, runs for 2 years. That means they end nursery school at 6 years or 5 years. Then they go to primary school that runs for 7 years. That means by the time they end primary, they are about 11 or 12 years. Then they go to secondary education, secondary school that runs for 6 years. So they finish secondary school when they're about 18, 19, 20, exactly. Then they go to university or in tertiary education. So our project is about secondary school students in the age range of 13, 12 to 18, 19, 20.
Thank you very much. Just to catch up where he stopped. Just imagine, and I love calling antimicrobial resistance the horror in the shadows. For us in Africa, it sounds like the horror in the shadows. It's some problem in the shadows, but we can't see it. We are somewhere where we hear about it, but we can't see it. So why are we increasing the knowledge in the very first place? And why are we focusing on increasing knowledge? Our point is to shine the light in the shadows. Can people see? Can people get out of the boardrooms and talk about it? Can people start having the conversation in the streets? Like we talk about malaria, like we talk about HIV, like we talk about gonorrhea. Can antimicrobial resistance too become a conversation that we want to see? So to go on, in our background, we say that when you look at microbial resistance, and in simple terms, this, if it's not tackled, is going to lead us into a post-antibiotic era. And when you look at sub-Saharan Africa, the basic background of our health system is more affected by infectious diseases. And you cannot talk of infectious diseases and before you talk about antimicrobials. So we are in a system that this is the backbone. And if they fail, we as the sub-Saharan Africa, we're also failing. Patients are going to die, we can't manage. And at the end of the day, we shall have increased mortality. The health costs will increase, and yes, we are not very developed in the sub-Saharan Africa, then meaning that we become more impoverished, and there are no new antibiotics being formed. We say that can the pharmaceutical companies meet up the change in the organisms? The organisms are changing. So it's very important for us to maintain the efficacy of the existing drugs. But we cannot maintain, we can't tell people, stop overuse, stop underuse, when they even don't understand what we are talking about. So we need to first bring this conversation out of these beautiful boardrooms and put it on the streets. And people have the conversation. And we shall start having the data dripping in, we shall start having the attention from the government, and even the people will start becoming responsible. Then we'll go on, when you look at the Global Action Plan, for us we looked at all of these, the 5 objectives of the Global Action Plan. We said no. When you look at the health professionals, we are here, most of us are health professionals, we talk about antimicrobial resistance. But the public education is at its infancy. The public is not informed in our country. When you look at the data that have been shown here, when you look at the most areas in the sub-Saharan Africa, we actually don't have the data. And why? Because there is no discussion. But talk about HIV, there is data. Talk about malaria, there is data. Talk about gonorrhea, there is data. But on microbial resistance, there is no data. Mr. Marco said we're gonna be advocates, but we need to show the gravity of the problem. And how do we show the gravity? Bring the discussion. Let us generate the data. And how first we have to have the awareness and the understanding. We can help the rest. So as we go on, what is our proposed solution? We said we looked at two streams. We have the downstream, we have the upstream. The upstream is made up of the old people, the parents and our grandparents, and the downstream is made up by the kids, the young people. And the young people are being determined, their health-seeking behavior and treatment is being determined by their parents. So what do we say? And the upstream where we have parents, these people have fixed perception. So changing them may take time, but we say the secondary students, we are in transition. He said it's between 12 years and 18. We're in transition. So we tend to adopt our own behaviors at that stage. And how do we adopt? The information we give her. We take it. So the more information we have, the more behaviors we get. So we are like, can we take on the secondary students? And here we ask ourselves, how knowledgeable are the secondary students? Does the knowledge increase after formal and purposeful education? We want to see this. We want to see this happen because it's not being done. In our system, this is the first of its kind. And the overall goal is to increase knowledge and awareness among secondary school students with the end result of a well-educated public. The secondary students are going to generate beautiful information, take it to the streets, and because they have an understanding with the public, we shall have a well-educated public. And how are we going to implement? We have the Ministry of Health, we have Ministry of Education, we have mentors, we have Infectious Disease Institute in Uganda, we have Makerere University College of Health Sciences, and then what is the Ministry of Health and Ministry of Education doing? Ministry of Health is guiding us, it has the action plan. Ministry of Education is going to help us simplify the information. We need the teachers. They get the very hard concepts, put them in a simpler manner. So we want to see the teachers come on board. At the end of the day, we are going to implement this in the 7 schools. We have the pre-education assessment, and as the pre-education assessment happens, we set the baseline. We start the implementation. And after the course of 3 years, we do the post-education assessment. We want to see students get involved in plays. Can they debate about antimicrobial resistance? Can they write essays about antimicrobial resistance? Can they do poems? Can we come up with quizzes? This is a conversation that will leave the classroom. As we leave the classroom, we talk about it in the streets, and our parents will be asking, what is that? And we shall be able to explain. As we go on in monitoring and evaluation, we are seeing we have the questionnaire on the baseline, we have the number of activities students are involved in, we have the meeting with our stakeholders, and we have the conferences. We are going to publish this data because in Uganda, I think the last time they published something about antimicrobial resistance is in 2015. And also it was just people's papers which they were doing for postgraduates to get academic qualification, but it's not focused. So we want to focus it. Then how are we going to meet the students? We are supposed to meet them once every 3 months in a period of a term runs for 3 months. So we want to meet them once every month in the first 1 year. Then in the second year, we can meet them once every term to see how are the activities happening and what guidance they need. And the innovation and the impact, we want to see that this can be, the way we talk about malaria and HIV and gonorrhea in classes, can they talk about antimicrobial resistance in the classes? Can the public get involved? Can health policies in the school, like hand washing, basic things, can they talk about that? Then the behavior change. We have seen people buying things, drugs over the counter. we want to see these behaviors because there's a conversation. If there's a conversation, like HIV and malaria, also a conversation can happen. Limitations. We are in Kampala. Kampala is the capital city, so we see students may be a little informed as compared to the outside. But this, we want to see that we implement it in FUMSA, which subscribes to IFMSA, where we go around the country. Secondly, there is little professional development for the teachers. But we are encouraging the Ministry of Health, and also we shall encourage teachers to be part of the training sessions. And the understanding by the team members, because we have artists. This is about behavior, it's about the veterinary doctors, it's about the public health. So the team members may not be well equipped, but we are going to have the discussion with them. We want them to understand, to tell us about the behavior, the social scientists, the veterinarians, to tell us how is the animal industry. And we want to see the education, the teachers, how best can we approach. And together, we can make a small change into the bigger one. Thank you.
Thank you, David and Nelson. Already we have a question. Theodora.
Thank you very much. You know that adolescent health is a very important global priority overall. And I know that school-based education would be very important. But in my experience with gonorrhea and with HIV, what the teacher says is always not believed. You know, they tell you use condom and all that. So I think you need to be more innovative in the way you need to deliver your education. And not just PowerPoint. You need to make sure that you have your peers. You know, the education needs to come from you. And that is what you need to be developing compared to only teaching the teachers. I mean, that's something that you need to be thinking in this project.
Yeah, maybe to just respond to that, we are a team of members. We have social scientists, we have the ministry, we have our mentors, IDI, MAC-CHS, the Makerere College of Health Sciences. These are professionals. So we are going to sit on the table and give them the information we generate. And they will tell us, can we modify it to this side? Can we deliver the information in this mode? Can we use pictures? Can we use videos? Can we be ourselves involved? So at the end of the day, we are going to have this incredible team, okay? Be there to refine. And at the end of the day, trust me, we are going to have a refined product. And everyone in Uganda is going to be talking about antimicrobials.
Not only about sex.
Thank you. I think Ingrid had a question.
Yeah, I have a question. It's on the same line as Theodora. I'm a bit more of using what is already out there. And there is an excellent educational program called eBug, originated in the UK. They have for primary school, they have for secondary school, and they have for young adults. At least to look into what they've done, because it's a lot of games, a lot of videos, and they have they're expanding to very many countries in the world, and they have translated also this course into many. So to not reinvent the wheel, but to look also what is out there, I would definitely recommend, because producing educational material is a hard job.
The good thing, Ingrid is here, so we have a pattern. He's going to help us talk to the UK guys, and we partner up, and we are going to make a good team. Thank you, Ingrid. Thank you.
Would you assess if the students, how they share this information?
Yeah.
Because for example, in France, some years ago, they did a campaign, public TV campaign, and they used the kids to reach the parents.
Yeah.
Then are you looking also how they share this information among their family or things like that?
Yeah, we are going to educate them, give them fast reading material, that's one, and encourage them to go and educate people back home with this reading material. This is, we have done this with NCDs. We have a project which is rolling out called Prevention and Early Diagnosis of Non-Communicable Diseases, where I went to the secondary school students, and we have interviewed them. Today, a secondary school student asks the mom, have you taken your blood pressure yet? No. Mom, you need to take it. Have you measured your blood sugar? No. Why? Because David and the colleagues talked about it. The medical doctors told us you need to know your blood pressure. And if mom finds it high, he's put on treatment. And we're achieving. So we're saying antibiotics are not different. Can we have the discussion?
Mark, that's 1 minute to read.
So, have you considered to develop a rap song about AMR? And second is, I don't know whether soaps are popular in Uganda, but have you thought about getting it into the script of soaps?
I love the innovation of Mark. You know, we as the young generation, we love hip hop. We want to talk about hip hop. Yo, yo, yo. So, we're going to consider that.
Oh, I think that's all. Thank you. All right, next off, we have Akme from India. But does it already exist, Mark? Have you seen a rap song on AMR?
No, but I have seen a rap song on HIV. That was 1.5 years ago in Paris when that was done, and I thought this is a very good idea.
And I'm sure David can implement.
I think there was a rap song about TB in Moscow last year at the Stop TB event too. There's an idea there. Once you're ready, so you feel it's fine.
Good morning, everyone. We are Team Acme from Kolkata, India, and I'm Digvijay Bose, and we're going to present a proposed project on antimicrobial stewardship in resource-limited healthcare settings. And this is our team, Digvijay Bose and Shatarupa Mukherjee. Now, the context and the background. As we all know, AMR is a global health threat, and the antibiotic consumption in India is shows that India ranks third in antibiotic consumption as in 2014 after China and the USA. And the antibiotic consumption has gone much up in India in the last years. As you can see, the use of cephalosporins have gone a threefold rise. And yeah, just a sec. Yeah, the antimicrobial resistance for E. coli, there is almost 100% resistance to aminopenicillin, penicillins, as we can see in this graph. So what are the causes, the major causes that we are targeting of antimicrobial resistance in India? It is mainly because of the consumers, the chemist shop owners, and the health service providers. That is leading to inappropriate and irrational use. Now, what do you mean by inappropriate use? By inappropriate use, we mean self-medication and non-completion of full courses. And irrational use include cut sell of full course of antibiotics that is mainly done by the chemist shop owners, as well as prescribing broad spectrum antibiotics unnecessarily. That is ultimately leading to antimicrobial resistance. Now, where aim is to assess the irrational and inappropriate use of antibiotics and ultimately to decrease it and reduce the unnecessary use, and our goal is to reduction of the burden of antimicrobial resistance in the community. So, we propose our solution. Our solution is that assessment of irrational and inappropriate use along with the formation of central monitoring body to which functions will come later. Now, the assessment is at consumer level, at drug distribution chain level, as well as the health service provider level, which will be regulated and monitored, and whose report will be sent to the central monitoring body. Now, solution at the consumer level. There shall be a QR code or a barcode present at every antimicrobial strip, and when a patient is going to buy the antimicrobial strip, the pharmacist will have to scan the code, which shall be linked with a specific software, and that software will note an unique identification number that is carried by the patient. And after the completion of the full course, the patient will have to return the empty strip to the pharmacist, and he will rescan. By this, we can get the necessary tracking of antibiotic consumption and information education and communication if necessary. Now, solution at the drug distribution chain level. This is the chain from the manufacturer to the pharmacist to the consumer, and back to the pharmacist for rescanning after completion of the full course. Now, as the strip goes under this chain, there shall be required QR scanning at every possible step, and because of this scanning, the entire distribution chain is going to get a certain subsidy, as well as we will get to analyze the entire chain and do necessary interventions by the central monitoring body, as we have already told. Now, the solution at the health service provider level, the central monitoring body is going to promote e-prescription, so provide trainings and orientation of medical education to the health service providers. Now, implementation at the consumer level. As we all were saying that while buying, the patient have to produce an unique identification number. Also, the thumb impression will do, because it will be noted in a specific software that is to be modified. And after buying, there shall be scanning of the strip, and after ending the course, the patient will have to give the empty strip to the pharmacist, who will rescan, and on this rescan, the patients will get 5% bonus to the bank or is in cash as applicable. And if they don't return, they don't get the bonus. And now the implementation of the drug distribution chain level, it is almost the same chain, and there is possible scanning, and for this scanning, there shall be 5% subsidy given to the entire chain, as well as the consumer returns, and this information is going to the central monitoring body for further interventions. Now, why the government provides subsidy? 5% to the consumer and 5% to the drug distribution chain. Because it will ultimately lead to the reduction of hospital stay due to the patients of antimicrobial resistance, reduction of prolonged treatment cost, reduction of AMR mortality and morbidity, that will ultimately benefit the government in the long run, and which makes this proposal a cost-effective and sustainable one. Now, implementation at the health service provider level, it is the promotion of e-prescription, and copy of which will be sent to the central monitoring body, and there shall be review of prescription by sampling, and if any discrepancy is found, there shall be reorientation programs, as well as regular orientation and CME programs and guidance and assistance. Now, the central monitoring body, as I was telling from the very beginning, there shall be different stratas from the central to the ground level through state, district and block. And the members of the central monitoring body, we are not going into the much details, but these members are already existing in different health fields in the country, and we are going to just assemble them to form the central monitoring body, whose main functions shall be software modification, orientation programs, publicity in all and print media forms, promotion and audit of e-prescription, maintenance of records, as well as initial orientation programs, e-prescription audit, and information education and counseling and awareness about AMR to consumer and pharmacists. Now, the measurement of impact. We have a certain planning elements and indicators and targets, of which some important are measurement of use of antibiotics, measurement of return, measurement of awareness and knowledge, and e-prescription usage. And we target to scan and rescan almost 90% of the antibiotic strips manufactured and sold, and 50% increase over the baseline score of the awareness and knowledge, as well as to include 100% of the medical practitioners within the programs. So the next part will be continued by Shaturba Mukherjee.
Thank you. Now the step-up interventions. For phase 1, we have taken into account for prescription audit, medical pharmacist training, and reorientation of the medical education, which is completely necessary for India, because in India, AMR is a global threat, and also increase in public education. For phase 2, we have proposed for laboratory upgradation in community health center level, because in our country there is no antibiotic susceptibility test at the CHC level, so the doctors take about, so the reports take about 7 days to come, and within this period of time, doctors they prescribe antibiotics, which and also there should be introduction of AMR topics in the school books, also a prospective feedback with replanning, and the already running health card project, which is in our country, should be amalgamated with the project, should be amalgamated with our proposal. This is our timeline of the project. We have estimated a timeline of 3 years. The resources, since this is our proposal and this is the existing government policies, our proposal can be amalgamated, can be merged with the existing government policies. And the Government of India shall provide funds for awareness program, formation of the central monitoring body, and for the software modification. limitation. Suppose I am a patient, I am buying a strip of antibiotic and the doctor has advised me to complete it for 10 days. But now, after taking 2 or 3 antibiotic pills, I am feeling better and I am just keeping I'm taking the 3 pills and I am storing the rest of the 7 pills. During a similar, and I am returning the empty strip, and as Digvijay said, I am getting the subsidy. But now, during a similar episode of illness, I may use the stored antibiotics, and this, in the long run, leads to antimicrobial resistance. Also, to get all the patients registered under this scheme, so that there isn't any unlawful buy of any antibiotic strip whatsoever. Also, people in rural areas, they opt for the quack medicines, and also there is unavailability of certain antibiotic in the government setups. Now the SWOT analysis. The strength is least resources is required in our project, but the weakness is the lack of awareness among the common people. The opportunity decrease in AMR burden in the community, and the threat is inappropriate and irrational uses of antibiotic. Now the budget for pilot project in West Bengal is coming to 0.1 million USD according to us. The expected impact, that is the reduction of antimicrobial resistance in the long run by the measurement of route mapping, reduction of antibiotic use during the viral infections and completion of antibiotic courses, reduction of unnecessary use of broad-spectrum antibiotics, and also the reduction of mortality and morbidity due to AMR. References? Thank you.
Thank you, Akne. All right, do we have questions? All right, Dewa.
Yeah, I think you're looking at patient compliance and having this card. I think this would be very good for a TB program, where you have a patient that would come back and forth for several times. You're looking at it at a longer period of time. While if you're looking at it as like an antibiotic for 1 week, I think it's going to be very costly, especially if you're looking at an incentive. I mean, it's not going to be, patients will not even come back. You know, they will just have a healthcare contact for once, and for them to come back is going to be very difficult. And having an incentive to go with it. In India, it can be misused, and also it is open. If you look at it, India, it's not probably sustainable to have that incentive system in place.
Okay, I have something to tell about this because in our country, for example, when a medicine costs rupees 100, that is INR 100, the government sells at the pharmacies which are connected with the government hospitals at rupees 33 only. They give 66.66% discounts on these many medicines. Now, what if the government sells this rupees 100 medicine at rupees, for example, say 80? Now, when after completion of the courses, the patient who has bought the medicine with rupees 80 returns, he gets another rupees 50 back in his account. And to be very honest, most antibiotics doesn't come within rupees 100. So that may be a huge benefit in part of the patients also.
All right, we have Arne and Delma.
About this question of subsidies, have you also think about universal coverage and health insurance? That, for example, if they will be fully reimbursed, they need to bring it back. I would think more sustainable to provide the subsidies when you implement health insurance and reimbursement of medicines.
Yeah, but in our country there is already a subsidy-based project running on the basis of a unique identification number, that is for the cooking gases or the LPG. So the subsidy-based model is already, already in motion, right? So it is very much acceptable to the people to get the subsidy. And for the, as you were telling, the health insurance, and that can be merged with the health card project as it was mentioned in the phase 2, because the health card was linked with that unique identification number, and it will store all the medical data of a person, whether it is a consumption of antibiotics, lab reports, prescription of doctors, everything, and that can be amalgamated with the health insurance too.
All right,
Yes, I have never been in India, so apologies for my ignorance, but my impression is that there is a huge informal, let's say, channel of getting antibiotics, and that it is not regulated. And your system is based on a regulated, let's say, formal chain. So how does that work? Is my, my understanding of how it works in India, is it wrong? Has it changed or?
Yeah, actually in India, what we do is that the pharmacists, they do a majority of cut sell of antibiotics. They cut the full course strip and they sell. That is actually leading to resistance. So what we can do is, we can keep a stringent law for the pharmacists that if you do this, and if you are caught doing this for say 6 or 7 times, or you will be under trial, or your license can get cancelled. And for mainly, what we can do is the information education counseling. That is the major purpose of this program, so that everyone gets aware of the fact that it is a major health issue.
But do I need to go to a pharmacist to get antibiotics? Or can I just
Pardon
buy?
me?
Can I just buy it at the market, or
No. It is always at the pharmacist only.
Okay,
you can get at the
what is the
open market.
definition of a pharmacist?
Okay, actually by pharmacist we mean the chemist shops. There are particular chemist shops in the country, and and also the government-based or hospital-based chemist shops. That's it.
There's 20 more seconds, so I don't think there's time for more questions. So thank you, Ahmed. So we're closing on the final teams. So next up we have anti-resist from India.
I think they're gonna change it, yeah.
Let's execute this.
Okay, but yeah, that's nice.
Hello, we're Team Anti-Resist. My name is Vinci Toshi, and that is my colleague Ravina Chadaria. And our proposal topic is Patient Antibiotic Use Documentation System, an open facet of modern healthcare. As we have already heard from our colleagues today, that India has been in the news for a while because of the NDM1 enzyme, which was discovered in 2010. And the main problem in India is for antimicrobial resistance. It causes around 58,000 neonatal deaths. India is mostly a rural population of with about 70% people living in the villages. There isn't there are high rates of malnutrition and poor sanitation and hygiene practices, which lead to recurrent infections. We have also seen that there is a global increase in the rates of malaria and tuberculosis, which lead to an increase in the resistance to antimicrobials as they get more, as they are prescribed more often. And this will lead to an increase in drug-resistant mortality. We have recorded cases of chloroquine resistance in some northeastern states of India. The burden of antimicrobial resistance is due to the barriers in clear doctor-patient communication, poor infection control and prevention practices. Logistical constraints involve the pressure on the physician by the patient to prescribe antibiotics, and this leads to an increase in the prescription of antibiotics. There is also an absence of surveillance mechanisms in India due to the absence of feedback. We also know that even if antibiotics are prescribed to the patients, they are used incorrectly due to the survival strategy where some patients save the pills for later use. The current National Action Plan, National Antibiotic Policy, does not take into consideration the two major contributors to healthcare programs, which are the healthcare providers and the patients. So our goal is to increase the, educate the students, the providers, and the patients about the importance and the side effects of antibiotics,
understand the severity of antimicrobial resistance, and also an implementation of practices to curb it on an individual, community, and a national level. To do this, we would propose to adopt the target toolkit in our local settings by formulating a hospital infection control committee, which already has an existing infrastructure in our setup with representation from clinical and non-clinical departments and administrators. It would also they would also be responsible for conducting audits, which are self-assessment surveys done after workshops, which will include 20 to 25 simulatory cases of common bacterial infections and assess their response to the appropriate prescription of antibiotics. We would also want in place a manual based on the nationalized guidelines provided by the NCDC and the WHO. And we would like to continue do workshops and presentations under the continuing medical education, as the importance of continuing medical education is the physicians will be aware of the current patterns of AMR. This will enable them to make better decisions while prescribing appropriate antibiotics. The parameters for assessment and evaluation indicators are knowledge, attitude, and practices based on the antibiotic use and the resistance, and also follow-up in the training. The appropriateness can be measured by the audits, and the behavioral practices can be assessed with a post-intervention post-workshop audit, and the antibiotic consumption can also be assessed with the change in antibiotic use measured in the healthcare setup. We have seen documented evidence on the role of patient education in the reinforcement towards antibiotic use. For example, France had a program which was antibiotics are not automatic, which resulted in a 26.5% reduction in the use of antibiotics for viral illnesses. The Get Smart program in the USA and Do Bugs Need Drugs in Canada have also shown good results. In India, we have a Say No to TB campaign which has helped in its domain and has really promising results.
So keeping in mind how patient education and information can lead to a change in antibiotic use patterns, we have proposed the introduction of the simple innovative tool for patient antibiotic use documentation known as the pod card. So on the outside, we kept some information for patient reference, which includes antibiotic use, some must-know information about infection control practices, some conservative management protocols for diarrhea and common cold, sore throat, and other such viral illnesses, and also to check the underuse of antibiotics in a rural setup. We've given some indications that require that essentially require you to visit a doctor or a practitioner, danger signs. On the inside, we focused on the patient antibiotic use documentation. So that would be filled in by the prescribing practitioner. After the identifying details of the patient are filled in, then the practitioner will fill in whatever drug is dosed at that time, and along with his sign and the date in place, plus any culture and sensitivity findings, if any, will also be mentioned. This is particularly important because we do not have a centralized system of collecting antibiotic use patterns, at least in our hospital, which is in a very rural setup. And even culture and sensitivity patterns are just now being documented digitally. So this could potentially be the only source for a patient going later on to a doctor, showing what kind of prescription they've had before. Also to note, all this information would be in the local language of the patient so that they can refer to it later, and also be easier for the doctor to reiterate it to the patient. So the overall sum up of our project is that at the heart of it, we have this hospital infection control committee, which is already existing, and they would have their monthly meetings, which are supposed to be happening right now, but are not kept in line. And at that time, they would have the chance to introduce the card and later on reiterate and emphasize on its use, along with hearing out any grievances and suggestions from practitioners as they're happening. Pharmacologists and microbiologists have an essential role, as they can get the target workshop, which is developed in the UK by the RGCP, RCGP and implement it to the local settings in our rural hospital. Along with that, we have to create a hospital essential drugs list in the form of a manual that the doctors can refer to, which can work in line with WHO's essential medicine list and NCDC's formulated list as well. So this is important so that second and third line drugs are identified and which can later be notified to the pharmacist and microbiologist when they're prescribed from the pharmacist in our hospital. So we've also mentioned independent pharmacists, so they have to just be notified that this card does not interfere with their practicing patterns, because otherwise they will discourage its use. The baseline indicators that were mentioned before can be collected and utilized to create a project proposal that would be used for scaling up to other subdivisions and tertiary healthcare centers, formally by coordinating with the district health officer, and then going on to coordinating with HICC heads of other tertiary health centers and other medical colleges to form a DICC, a district infection control committee, to implement the principles in the project, in the pilot project overall across the districts. Also informally, we have coordination among district-wide microbiologists through social media, so they can themselves coordinate and communicate about how the project is running in the respective medical college. We also like to focus on the introduction of a student antimicrobial control representative. So some weaknesses and threats in this are that microbiologists may not be certified under stewardship program, so in that case ICMR's program is available. Also, poor physician motivation and patient compliance is a problem, but that can only be curbed by creating an intervention program through the HICC and then causing the physicians to educate the practitioners of the patients further. The runoff phenomenon can only be curbed by continuing education and emphasis. So overall, working on with a problem tree in the beginning, we aim to focus on creating a scripted guideline for the physicians to follow so that they can communicate this to the patient and there is some information dissemination. Along with that, we want patients and practitioners to recognize the value of antibiotics. Okay.
Thank you so much, and I resist questions.
I will start with the on this card here. Does this targets all patient ages? For example, what about the young children?
Yes. So that's
Very young.
So diarrhea is mostly a problem in the pediatric population. So that's why we mentioned it separately, because that's the case where antibiotics are prescribed unnecessarily. So we want to focus on the management separately than that.
We would like to emphasize the conservative management because when the patient takes their child to the outpatient hospital, the doctor can, the physician can inform them that these are the conservative methods that you can use, which would be beneficial as opposed to giving an antibiotic, and this would be more helpful in improving the health of the child.
Right. Other question? All right. Thank you. Anthony.
So how does this extend really beyond the traditional sort of approaches for antimicrobial stewardship? The sort of things that we see in a lot of hospitals of infection control committees. So what would you say is your innovation?
The main thing that we're trying to do is creating this hospital infection control committee with focus on intervention to carry forward. So the principles are communicated and they have a chance to actually utilize that information and communicate it to their patients through this. And also there's a feedback loop that's created because of the surveillance methods which aren't currently in place along with the HICC.
So this is different from the traditional stewardship committees. There are infection control committees, they don't really have an education function and things. So how would you actually empower and actually get the hospital administration being motivated to do this? What would be their motivation?
But we have a very motivated microbiology department right now, and their only concern is that the HICC isn't functioning as frequently as it should, and it doesn't have a focused, you can say, principle that they want to follow. So in this case, it's mostly about giving more focus to the microbiologists and the pharmacologists so that they can implement the principles that they already know about antimicrobial resistance further along to patients.
And I was very interested in your ability to actually take this product up to the district level. Can you tell us a little bit about how that would work? This would go beyond an individual hospital, is that right?
Right, so we wanted to use currently there are no baseline statistics to start with, at least in our hospital where we wanted to create as a pilot project. So from creating baseline indicators, we would see how implementation would further work. So every month there would be the HICC meeting where the cards used would be emphasized, and along with that, every 3 months the target workshop would be held to again emphasize on how infection control practices must be done, and on simulated cases and the treatment protocols that must be followed. So keeping that in mind, we want to see how baseline statistics will shift, and accordingly create a project proposal that will be disseminated to the district health officer so that coordination could work there. These are already existing methods that we have to further a project proposal. We just want to create something concrete by showing changes in physician outlook.
That's great. So the collective action possibly at the district level could engage multiple hospitals. So that actually might be a great opportunity to have mobilization done.
Sorry, thank you so much. So that was the final team, but we're still going to read out the answers from the global health enthusiasts to the questions that were sent to them. So the first question by Mark was that the project is promising. What do they consider the most significant obstacle for their success, and how would they overcome that obstacle? And the answer reads, a significant obstacle is getting the collaborations and cooperation we need both from the regulatory bodies of pharmacy and the Ministry of Health, which we consider as the representative of the government on health issues. For the pharmacy regulatory body to incorporate the controlled access of antibiotics in the laws of the society, this might also involve a lot of politics. And then the closure of antibiotics market will also be a challenge. And then although the government has made previous moves to achieve this, success is still in prospect. The closure of the market will be the rate limiting step in achieving a success in this project. Then the next question was about will the card only be used by patients and pharmacists or by also healthcare centers where prescriptions may often be secured. If this is started with antibiotics, can and should this be used with other drugs that must be conserved? Yes, all the healthcare centers, this is the answer. All the healthcare centers where prescriptions are being issued, this card will be used to purchase antibiotics from the central drugstore by pharmacists or the authorized healthcare professionals, not the patient. The pharmacist or the healthcare professional issued the card will be able to buy the antibiotics from the drugstore through the online purchase, while the patients will be able to buy from the pharmacist or get it from an authorized healthcare center. The card will not be made available to the patent drug vendors, so they won't be able to buy the antibiotics from the central drugstore. The government has already made the dedication to close down open drugstores in December 2018. The idea of the use of the smart cards to buy antibiotics will make it possible to strengthen the supply chain. In fact, this is a big incentive to the pharmacist and to the healthcare center, because to access antibiotics, the patient needs to go to the pharmacy or the healthcare center where appropriate clinical intervention can be done, rather than purchasing the antibiotics from a patent store or other illegal means. also to monitor the sale of the antibiotics in the pharmacy or the healthcare center. The antibiotics register where the number of antibiotics procured will be recorded, and the prescription of or the lab orders to dispense the antibiotics must be documented. This will make it easy to monitor the sale of antibiotics in the pharmacy by the regulatory body. Since the amount of antibiotics ordered by pharmacy will be documented in the online database of ordering website, which can be used to track illegal dispatch of antibiotics. And yes, it is scalable. It can be used for other drugs that must be handled with care. Third question, what types of incentives would they have for pharmacists not to turn to the black market or the flourishing informal markets? The answer is, once the open black market is closed, there will be no black market to resort to, as mentioned in the previous answer. Also, since pharmacists are aware and educated about antimicrobial resistance, this will be seen as a way to tackle AMR. Also, since PPMVs will no longer have access to antibiotics, this means that all requests to antibiotics will be to the pharmacy. Hence, there will be more sales of antibiotics in the pharmacy, which is another incentive. Also, patients will be assured that they are getting appropriate care, hence they will be motivated to get antibiotics through the right means. In rural areas where there are very few pharmacies, antibiotic centers will be instituted in a way that ensures that patients always have access to antibiotics when they need it. The next question, if you start having a specific card for antibiotics, but this was the same question that we had before. And the final question is how will the team work through changes in the regulatory supply of antibiotics, including the buy-in of the Minister of Health? And the answer is yes, all the healthcare centers where prescriptions are being issued, this card will be used to purchase antibiotics from the central drugstore by pharmacists or the authorized healthcare professional, not the patient. The pharmacist or the healthcare professional issued the card will be able to buy the antibiotics from the drugstore through the online purchase, while the patients will be able to buy from the pharmacist or get it from the authorized healthcare center. This card will, no, it's part of the previous answer. This card will not be made available to the patent drug vendors, so they won't be able to buy antibiotics from the central drugstore, as once again, that was mentioned already. And the final point was a complex project to change the system of supply. How do you expect to do it? We don't expect to pull it off alone. This is why we're involving collaborating with other bodies like the pharmacy regulatory bodies, government, software experts, and stakeholders in the health profession to make the implementation a success. It is important to note that the Pharmacists Council of Nigeria and the Ministry of Health also plan to close down the open drug market, which makes it easier to fulfill the project. So that was their answers, and once again, apologies for global health enthusiasts for having such a hard time in actually reaching our judges. But that was all the presentations. AMR kills, but so does sinning, so it's time to kind of start moving around. Thank you for all the judges for listening to the projects, and most of all, thank you all the teams. When I was listening to your presentations, I kind of was thinking that an idea that I had, a concern that I had when thinking about the Innovation Challenge on AMR was that are students actually interested or motivated to tackle such a complex issue? Because that's what AMR stewardship is. It's not the most easy subject to tackle, especially because we receive no official education on the subject. And what made me really happy is that you've gone to really great lengths to actually learn about the stewardship and all done independently. So whatever happens once you get back to the countries with the implementation, so do not stop learning, because this is a huge issue, and I'm really motivated myself to kind of see the effort that you kind of put in your projects, because that was just wonderful. And there's a surprise, the judges have promised to provide us with one outstanding presentation award, which will be given then tomorrow. So you can still be excited for that then. But we are a bit behind the schedule. I think the fault is mine. But there's now 15 minutes to go to the lobby to get your lunches. And do it quickly because then we have to come back because we have Brenda Veni, who's already here to give the next lecture. So, off you go.
Gonna go now and try to get the videos of Mark and the judges first.